following is a conversation with Professor Konstantinos Yerasmididis, a professor in clinical nutrition at the University of Glasgow, who has a special interest in the gut microbiome and dietary interventions to treat disease. We also had Dr Richard Hansen, consultant paediatric gastroenterologist, who was on episode number 1 of the Inside Matters podcast. He's moved now from the University of Glasgow, Glasgow Royal Infirmary, and Ninewells Hospital. This was the first time I had 2 guests participating in the Inside Matters podcast at the same time. It was an absolute pleasure. It was a lot of fun. Given that Costas and Richard are experts in inflammatory bowel disease and that they've collaborated on several different research initiatives, we spent a lot of time talking about inflammatory bowel disease, in particular the 2 subsets of inflammatory bowel disease, Crohn's disease and ulcerative colitis. We spoke about their work, which is focused on using nutrition and personalised dietary therapy in the context of Crohn's disease in particular. So they've been involved in a program called CD Treat, where they've tried to mimic the effects of something called exclusive enteral nutrition, EEN, essentially an entirely liquid diet with a diet that contained real food. Why is that important? Well, for 4 out of 5 children with newly diagnosed Crohn's disease, a form of inflammatory bowel disease, this exclusively liquid diet has a profound impact on the Crohn's disease. So 4 out of 5 of them go into what we call remission, i.e. no clinical symptoms. That's amazing, right? But there's challenges associated with EEN. Most notably, it's very restrictive. You can't eat any food for 6 to 8 weeks. So what Costas and Richard have been trying to do is, can we give children and potentially even adults a diet that contains the same components as a liquid diet, but allows people to eat real food without having to have an exclusively liquid diet. So that was fascinating. We also talked about some common myths and misconceptions associated with the microbiome. We asked the question, does the microbiota cause obesity? We also spoke about the microbiome field more generally and how it's progressed over time, and some of the challenges that both the field and the academic researchers have faced over the last decade. But it's not all about the challenges, of course. We've also talked about the positives and the ups and the successes that we've had together. This is a really interesting conversation that I think should be accessible to most of the listeners. We did go quite deep on some areas, but we always brought it back to, well, what does that mean for the listener and what can the listener take away from it? I believe that you will particularly enjoy this podcast if you're someone with inflammatory bowel disease, if you know somebody suffering from inflammatory bowel disease, or you just have a general interest in that topic. You will also enjoy this podcast if you're interested in diet, nutrition, and how the diet interplays with the microbiome and how the microbiome interplays with the rest of the body. We talked a little bit about fiber, probiotics, supplements. So if you're interested in these things, then there should be some nice content in there for you as well. As always, I wanted to thank you all for the support that you're showing for the podcast. It's been over a year now since we started Inside Matters, and I've been really humbled and delighted with the progress and the traction that the podcast has been receiving, particularly in recent months. If you're enjoying the podcast, please follow us on socials. Please reach out with any topics or suggestions that you have. I'm absolutely loving hosting it as your host. This is Inside Matters. My name is Dr. James McElroy. I hope you enjoy it. I'm the worst culprit. I just get too excited.
If you want to do the intro first, that would be a sensible place to start.
No, because I've changed the way I do my intros now. I talk about the episode and what we learned and what we didn't learn. So don't want to kind of... Yep. Thanks so much. Thanks so much.
I'm Dr. James McElroy. This is Inside Matters. I invited these 2 guys hoping to learn something. Didn't learn very much. We meandered for an hour and a half and then we all went home.
We are going to learn, the audience are going to learn heaps. I'm absolutely sure. This is actually the first time I've had 2 people on at the same time. I'm genuinely excited about this. I know I'm going to learn a lot. And if I'm learning a lot, then the audience will learn a lot. So why don't we start with something easy? Because you're both experts. This should be straightforward. What is a healthy microbiome?
Ooh. What is a healthy microbiome?
I don't think there's a clear definition of what is a healthy microbiome. I think at the moment we just get it as granted that is the microbiome of people who don't have a disease.
Yeah, I think that's fair. I think it's a really important question. It's almost a fundamental question, and it's disappointing that after a decade in this thing that we can't really answer that. And I think one aspect of that is that your healthy microbiome is different from my healthy microbiome, right? So if I suddenly had James McElroy's microbiome, I might be going to the toilet all the time, do you know? Because yours
I would hope that you'd see a whole load of benefits.
I'd probably be like tremendously grateful for the rest of my life. But, so it's host specific, and that's important. And it's functionally important, and it's not pro-inflammatory. Those are functions or features rather than actually characteristics in terms of how it's made up. But it might be that a microbiome in one person that was perfectly tolerated and fine, transplant that into another person, and it might cause them an issue because it's not compatible with, what they need or what they're looking for. So I don't know anyone can answer that question yet, but we should be able to answer that question.
Yeah, but I think we should move towards the definition of the healthy microbiome, and I think we have to take into account what factors contribute to shaping our gut microbiome. So diet is one of them. So if we assume, for example, that people who've got a healthy diet will have a healthy microbiome, then perhaps in the future we should be looking at studies where we give people what we consider as a healthy diet and try essentially to use the microbiome of these people as the healthy kind of like benchmark of the microbiome. The same way, for example, that we do for the growth of children. So at the moment we define as optimal growth in a child, the growth of a child who has been born in the right environment, had received breast milk, the family didn't have any kind of morbidities or comorbidities, and there were no kind of socioeconomic factors to consider. So I think in the future, people actually may think of a healthy microbiome the result of people who were born and grew up in their ideal environment, they received the right type of diet, and this is the benchmark that we may set.
What's quite interesting about that, this is where my paediatric background is quite useful, is when we talk about growth of children, we hitting the microphone here out of excitement, we talk about centiles and different parameters of growth, people who grow very well, people who don't grow as well, but they're still considered normal. Yeah. So there's a range there naturally within anything that you consider normal, right. People who are taller or shorter as a range of normal. And maybe we need to think about that for the microbiome as well. It might be that you have people who have relatively super microbiomes that are protective and beneficial and help them do things like digest seaweed, and people who perhaps don't have some of those features, but still it doesn't cause them any pathology or any sort of secondary considerations.
Other parameters that we can use to try and characterize healthy, because I know there's no mutually universally agreed definition per se of a healthy microbiome, but other parameters, characteristics like diversity, or you mentioned pro-inflammatory. Is there some way of breaking it down to that kind of level? Yeah,
I think there are kind of certain markers that we consider them as indices of a healthy microbiome. Alpha diversity, so the more bacteria you've got in your gut, and the more equally distributed these bacteria are in your gut, it is currently considered as a marker of a healthy microbiome, as well as certain kind of functional characteristics. So we know, for example, that short-chain fatty acids are very important for gut health and actually beyond our gut. So, for example, a microbiome which is associated with increased production of butyrate. Again, this is a characteristic of a healthy microbiome. But again, one of the things that we have always to bear in mind is what is healthy for you may not be healthy for someone else, particularly if someone has a predisposition to develop a disease.
Are there any traits or characteristics or trends which are kind of universally observed in disease states? And I'm pushing on this because I want to get on to using the microbiome to diagnose disease.
Yeah.
Microbial therapeutics,
Yeah.
Are there any characteristics that are sort of universal across patient populations?
The most studied one is diversity, probably.
Yeah, that's right.
And there is a suggestion that lower diversity is associated with disease states, with IBD being the classic one. And I suppose what I probably have an issue with diversity now, 10 years into this thing, because it's just maths. It doesn't really tell you what's going on in that microbiome. It just tells you that there's less abundance of things than there is in another one. And when I talk on this, I give a slide of a rainforest with lots of diverse species in it, and then I give a slide of just a tree with a wee shrub next to it, and I talk about one is a very diverse population and one is a low diversity population. But that doesn't necessarily mean that the low diversity population is wrong or is not suited well to that habitat. And I suppose we have been through an era where we've done what we can do to understand and explain these data sets, these quite complex data sets, and diversity is one way of doing that. Principal components analysis, where you plot them onto a figure, and the closer you are to another one, the more similar you are to that other one. We've kind of relied on these things for quite a long time, but actually I think the point that Costas makes is a really good one. Actually, stop thinking about things like that, start thinking about other things like function. What does this microbiome do? Does it actually help you with butyrate production, which is an essential fuel for your colonocytes? So good butyrate production should be a characteristic of a good, healthy microbiome, and that's something we can measure. So we probably need to get better at looking not just at the computer, what it tells us about what's there, or even these mathematical indices representing that, but actually integrating that with things like function. And actually, you're very good at that, I would say.
Yes, and of course, it's also important to take into account not just broad markers of microbiome, kind of like diversity, because, alpha diversity is an estimate of how many different species you've got and how equally distributed these are. But you can have two people who may have the same diverse microbiome, but, they may have different taxa, different organisms. Some of them, for example, may have more beneficial organisms compared to someone else who has the same diversity, but his microbiome comprises mostly of pathogen or pathobiont organisms. So, going back to your question, James, is in most of the studies where there is inflammation in the gut, we see a low diversity. And of course, the question here is how much of this is primary and how much of this is secondary effect,
Right.
because we know that having inflammation in your gut can affect your microbiome as well. And quite a lot of the excitement about diversity and disease comes from cross-sectional studies, or from people who already have the condition. So it's at the moment quite unclear how much of this is primary effect and how much of the secondary consequences of having gut inflammation.
I think that's really important, cause and effect, isn't it? So if you have bowel inflammation, let's just talk about ulcerative colitis as an example of that. Ulcerative colitis, bowel inflammation, you have diarrhea, intestinal hurry, you have blood in your stool, you've got a pro-inflammatory environment, maybe not an ulcerative colitis, but certainly in Crohn's disease, you might have malabsorption as a feature of that as well. So your intestinal luminal environment is very different. Things are rushing through. And so it's probably not a big surprise then that when you look at the diversity of what comes out the bottom end of that, literally at the bottom end of that, that is lower because it spent less time in there, and actually it's been a different ecosystem, or it's a different environment. And so how much of this low diversity or the reduced diversity that we see is actually about the pathogenesis of the disease, and how much of that is an effect of the disease and its processes. And I don't think we've got an answer to that yet.
And if I'm allowed to add also diet, because when you've got active disease, your diet is changing, the amount of the food you consume is different, and the composition of your diet is different as well. And there's now good evidence to suggest that the main determinant of your gut microbiome composition and function is your diet.
Yeah.
And in these studies, we're talking about how many of them actually assess the diet as part of the intersection between disease and diversity.
We're getting better. The very first studies didn't do that, but also how you assess the diet is a very important factor. So sometimes people are thinking that collecting some information about the participants' diet by asking them questions about how frequently they consume certain food is what you need, but actually we now understand that assessment of dietary intake is a very complex thing to do. So in our kind of like our own research team, we prefer to give people certain dietary interventions as opposed to retrospectively record the diet they consume, because you've got more noise by doing the latter as opposed to the former, right?
Yeah, I guess, can you remember what you had to eat 3 days ago?
No, I can't remember what I had to eat this morning.
It's hard, right?
It is hard.
And so could you just give us sort of your expert view on how best to track and assess the diet if people are sort of inherently unreliable?
It is, it depends very much, James, what you want to do here. So, generally speaking, in dietetics and in dietary assessment, we divide dietary assessment methods into two main categories. One is what we call retrospective methods. So basically you ask people what they consumed in the past. And the other category is what we call prospective methods. So basically you ask people to prospectively record the diet they consume.
Right.
Now, if you're interested about the diet you consume now and how this diet will influence your microbiome, it's better to do this prospectively.
Yep.
And it's even better actually to ask people to consume the diet that you give to them. Okay, but when you try to associate, for example, disease onset with dietary habits, then you're looking obviously at the past, and there are very, very few methods you can use to do that, and most of these methods are quite inaccurate. Most of the time, for example, we use what we call food frequency questionnaires, so we give our participants or our patients a long list of questions about food they consume, how often they consume, and then based on these 150 questions, we try to work out their dietary patterns. So basically, if they eat more meat, more dairy products, less fiber, and of course try to associate these dietary patterns with features of their gut microbiome, composition and function.
And you mentioned that you're in your practice, in your research, you're more interested in giving patients something specific. Why is that?
Because we can control what we give to them. We can even analyze what we give to them. For example, for the studies we've done with Richard, we give patients with Crohn's disease a diet that we developed in our lab. We have asked the catering company to develop this diet, to distribute this to the participant houses, but have also assessed the composition of the diet. We also measure parameters which associate with compliance to this diet, because quite often when you give someone a diet, you're not quite sure if these participants consume the diet you gave to them, or they're not kind of like consuming something else, or they're cheating. So in our hands, the best way to assess someone's dietary intake and how this dietary intake can influence the gut microbiome is to give them a specified diet, particularly with food that you have provided to them, but also to assess compliance to these dietary restrictions or dietary recommendations.
Very few people do that.
And very few people do that.
It's hard.
It's hard and it's expensive.
Yeah. But this is what I would call the gold standard way to assess someone's intake and how this diet influences the gut microbiome.
And the both of you have been collaborating on a variety of different projects for quite some time. Could you just pull out for the listeners some of the key things you've learned through the research that you've done together and how that might impact on patient care?
Yeah.
Right. Okay.
Do you want to go for it? Do you want me to go?
Go ahead.
I think the broad theme of what we've probably done together, and not just the two of us, there's a big team, of clinicians and other scientists, particularly within Costas' lab, and charitable partners, and all sorts of people who've supported us, and of course the patients who give endlessly of their time and their energies to support that. So nothing is about the two of us, and it never is. We just happen to be the ones that are here. But I think the broad theme of what we do or have done together is to try and understand how nutrition works as a therapy for Crohn's disease. Because we know it does. And this is a very paediatric orientated question, because paediatricians for a long time have used nutritional induction for Crohn's disease to switch off disease and heal the bowel and to make people better.
And for the listener, can you just talk us through that? And if you want to learn more, you can go back to episode number 1.
So we're talking about, and I just came here to repeat everything I said in the first episode, wearing different clothes, right? So exclusive enteral nutrition is a liquid only diet that we use for 6 to 8 weeks with no other solid food, and we use that to switch off inflammation of the bowel, heal the bowel. It works in 4 out of 5 children with Crohn's disease. And the reason that it's actually taken off in children is because early studies suggested that it was as good as steroids, but it was better for you in terms of growth. That might be something that we can come to, because I'm sure Costas has got things to say about that. But early on, Costas' work really showed that this works in a paradoxical way when it comes to the microbiome.
Can you just pull that out? Because that's quite interesting, isn't it? Like no fiber,
Yeah.
That's right.
Fiber's
You want to talk about it?
Yeah.
Fiber's supposed to be good.
Yeah, so that's an interesting story because most of the what we call observational studies, so basically studies which associate your gut microbiome with risk of disease development, suggest that a microbiome which is more diverse, where you've got more butyrate, more of these beneficial short-chain fatty acids, is associated with a reduced risk of disease development. But when it comes to the management of Crohn's disease, we have this paradox. So essentially, we can effectively treat active inflammation by giving children a diet which has zero fiber, a diet which is suppressing the gut microbiome, a diet which is suppressing these beneficial fiber-producing, fiber-fermenting species, and a diet which reduces your butyrate concentration by a factor of 3.
Wow.
Okay, but despite all this kind of like suppression of the gut microbiome, these children get better, and we've got improvement in gut inflammatory markers. And, this is quite counterintuitive data.
So if you go back to that first conversation we had about defining healthy, and you sat with a blackboard and you started to write down things that we think mean healthy, then you'd have the opposite of all those things on it.
That's fascinating.
So it's totally paradoxical.
So what you're saying is you're essentially intentionally giving a diet to reduce diversity.
Yep.
Which is paradoxical because we talk about diversity being good, and to promote diversity, you want a broad range of substances that the microbiome consumes that allows them to replicate, and that would be fiber and polyphenols.
But another example I usually bring up here is, we know, for example, that gluten is fine for you if you don't have celiac disease. Cow's milk protein is fine for you if you don't have cow's milk protein allergy. But if you do have these ones, then they're not good ingredients for you to consume. So perhaps for certain people who've got a predisposition to develop Crohn's disease, a very diverse microbiome may not be the expected one, or the...
Can I just press you on that, just as an expert in nutrition and the microbiome? So we've had people come on here who say things like, if you want to reduce gut symptoms, you want to reset your gut, you need to cut out gluten, cut out coffee, cut out all dairy, drop alcohol. Is there any truth to any of that in terms of the gluten and the dairy? Is there any reason to actually cut out gluten and dairy if you're not celiac or you don't have a...
Okay, so let's start with the dairy. Dairy is easy because there are trials to show that if you cut down your dairy, you don't get better. And actually, the treatment that Richard referred to us, the exclusive endocrine nutrition, this liquid-only diet, is produced from dairy milk. Okay, so it's basically is made of cow's milk. So I don't think that dairy have an important role in the management of active Crohn's disease.
But what about for the healthier person who doesn't have Crohn's disease? Because some people say things like humans are the only animal to consume another animal's milk. So should we be drinking it? Is it good for our gut? Does it cause inflammation?
We're also the only species that's landed on the moon. Do you know? There's a lot of things that are different about humans that I think when you try to just associate us with every other...
It could be aliens who've done it.
Maybe it was a hoax. Who knows? I don't believe that. I just say that very quickly before I get a different set of Twitter followers. Right. I think it's... I think it's a difficult thing. Actually, this comes up in the clinic all the time. Is about allergy testing for children. Can you test my child for allergy? And which is, as a concept, as a question, which is a difficult one to answer. There's really kind of two types of allergy testing in children. One of them is to do blood-based RAS tests, which look for IgE.
Yeah.
And the problem with them is they can be positive when you have no allergy and negative when you have an allergy. So that's not all that helpful. Mm-hmm. They can be used sometimes when you really think a child has got an allergy and you don't know where to start. And so you do it as a kind of indicator of where you're going. The second one is skin prick testing, which you kind of need to have a skin-based reaction to the allergens to do that. So both of those tests can be negative and you can still have an allergy testing, okay? Yeah. And that causes a problem. So the gold standard you're left with, and this is, I'm coming to the point, I promise you.
No,
the gold standard you're left with is to take something out of your diet and see what happens, and to put it back in again and see what happens. And in the absence of life-threatening allergy, so the kind of peanut-related anaphylaxis that people hear about, someone who maybe has a bit of tummy pain and a bit of a rash related to cow's milk, but it's not something that's ever going to be fatal or risky to their health, you can take it out, see if they get better, put it back, and if it comes back, you know where you are. And it's a really nice test to apply to any aspects of your diet. So, if people are listening to this and they want to pursue your concept of taking dairy and caffeine and alcohol and fun out of your life and to be better as a result of that, then I'm not equating alcohol with fun, by the way. I'm just being
just to be clear,
little bit.
It can be fun, though.
A little bit.
Yeah.
Oh, of course it
In
can
moderation.
be fun. Anything.
Yeah.
Fine.
Yeah.
So if you take something out and you feel better, great.
Yeah.
Put it back in again, see what happens. If you still feel okay, maybe you were over-interpreting something else that happened in your life about you changing your job or your environment or getting new friends or whatever it is, or getting a raise, going on holiday. But actually, if you take it out and you feel better and you put it back in and you feel worse again, you probably are better taking it out.
There you go.
There you go. Why not do that?
Yeah, but it's also very important to distinguish between what we call functional symptoms and organic symptoms, because, caffeine, alcohol, gluten are normal stimulants of your gut motility, okay? So it's a difference between having active disease, disease which is associated with gut inflammation, as opposed to have symptoms because you've got, you consumed food which produces naturally a lot of gas and increases the motility in your gut. So it's a very fine line to distinguish between what we call functional symptoms as opposed to active organic disease and inflammation. We've got biomarkers that we use in clinical practice, but obviously these are biomarkers which are not accessible to the common public. So
the general public who wants to try and take control of their symptoms.
Yeah.
But another concept that's useful is to do one at a time. Don't take sick things out of your diet and then try and assess what's happened. Do you know?
Yeah.
Particularly if it's about seeking a small benefit. Do you know? If you're seeking an enormous benefit, and we do this in clinical practice as well. Sometimes we do have to do this. If we have a child who's very unwell from something, and we think there's a food element to this, sometimes we'll put them on what we call a few foods diet, where we take nearly everything out and we give them some pretty safe proteins and not much else. And see what happens, and then build them up one at a time and watch from there. Or in eosinophilic esophagitis, which is an allergic condition of the esophagus, we take 6 foods out of the diet all at once, because they're the kind of target foods that would usually be precipitants of the problem. So we sometimes do that, but I think if you're looking for something small and fairly subjective, don't take 6 things out of your diet at once. Take one thing out of your diet at once.
That makes sense.
And this is where dietitians are really important. Certainly in children, don't take anything out of a child's diet as a main food group without speaking to somebody about that first. And definitely don't take dairy out of a child's diet without knowing where their calcium intake's coming from.
And vitamin D.
Yeah, and vitamin D, yeah.
Now, I'm going to press pause on this because we're getting to something really interesting, which is the foundations of nutrition for kids and how you can help them grow in their microbiota. I just want to go back 1 second to your research, because I drew you off piste.
Okay.
So you were talking about some of the key things you've learned from your research, and then we'll come back to foundations for children and microbiota and how it develops through age and time and so on. So back to your research, talking about dietary interventions, Crohn's disease.
I think, as Richard mentioned, all our research about the role of gut microbiome and Crohn disease and diet started from our own observations, showing that when you treat active Crohn disease with this liquid diet, children get better, and the diversity of the gut microbiome is decreased, and the total number of bacteria are decreased as well. For example, when you treat children with this liquid diet, you've got a reduction of the total microbial load by a log of 1, which is pretty much a 10-fold decrease. So based on this kind of science and the experience we have had with the use of this liquid diet, we decided to develop a food-based dietary therapy. So it's essentially a diet which has similar composition to this liquid-only diet, and a diet which has the same effects on the gut microbiome. So we developed this diet, what we call it CD Treat. So this CD Treat diet tries essentially to mimic the composition of the liquid diet. And we tested this diet, first of all, in healthy people, just try to see if, let's say, the new diet, the CD Treat diet, can induce the same changes on the gut microbiome as the liquid-only diet.
And
so we achieved that, yep. So we did that in a very small, what we call crossover randomized controlled trial. where we gave healthy people this new diet for 7 days, and we compared the effects of this diet against the liquid-only diet for the same period of time. Then, of course, we wanted to double-check and confirm our findings in an animal model of disease. So in this case, we used a model of gut inflammation. So these were rats who were fed this new diet against the liquid diet for 7 days. Of course, we had to sacrifice the animals. We collected luminal samples, so basically their gut microbiome. We assessed the gut inflammation at the gut level, and we have shown that the effect of the new diet is similar to the liquid-only diet in terms of improving the gut inflammatory markers. We measured, for example, certain cytokines, and the gene expression of these cytokines was reduced. And we have also performed a histopathological analysis, and again, we have shown that these effects were comparable. And of course, you start working with humans who are healthy people, then you're going to animals who have a disease, and the ultimate study to perform is to take all this preclinical, as we call it, data and try to translate that to clinical research. So we performed back then a small trial, which is now a quite big trial. So we started with 5 children who had active Crohn disease. We gave them CD-treat for 8 weeks, as we would normally do with EN. We have observed that 60% of these children had no symptoms after I received CD-treat, and in half of these children we had normalization of the calprotectin. So basically, not normalization, the calprotectin dropped by 50%. Of course, all this data together, take into account preclinical data in animals and healthy people, and this pilot data in children with Crohn disease helped us to make a strong case to pursue this in a much larger population. We received funding from a philanthropic organization in the States. We have recently completed a study where we have tested CD-treat in 60 children and adults with Crohn disease. The results look good. Our original observations are confirmed, and we're in the process of publishing this work.
Are you able to disclose what CD-treat is from a kind of food group? Is it burgers and chips? Is it iron brew and bacon butties?
I get asked that a lot.
Yes, we're asked this a lot. And I think, as I told you before, what we try to do with CD-treat is we try to mimic the composition of EN. So basically, we know that exclusive enteral nutrition, or this liquid-only diet, is gluten-free, it's lactose-free, it has no fiber, and it has a certain kind of like composition in terms of carbohydrate, fats, and protein. So what we try to do, we try essentially to replicate this diet by using normal food. And in theory, you can use any food you want, as long as in the end you deliver to this child the nutrient and the food ingredients of EN.
Could you go a step further, do you think, and try and delineate the sort of lactose, gluten, which element is actually maybe having the biggest driver of reducing the inflammation?
And I think we will. I suppose it's important to point out that I think the journey that Costas describes that started from the healthy volunteer study, I think started in 2014.
That's right. Yep.
So it takes time. It takes quite a long time to do this. And actually, I don't think our hypothesis with CD-treat was if the liquid component isn't important. That's not important at all. The solid versus liquid doesn't matter. What matters is what the composition is. That's probably the kind of underpinning hypothesis behind CD-treat. And if we could match what was in the liquid with foods, then it would do the same thing. And I think we're proving that point. And what that then gives you is we don't really have hypotheses necessarily that gluten or lactose or, fiber's a slightly different one, I suppose, that these are important in the therapy for Crohn's story. Probably we believe that they're not, but that's a separate conversation. But what CD-treat allows you is a baseline from which you can say, right, CD-treat 2 is going to be the same, but we're going to put gluten in. because you can then test it. You know your first one works, you've added one component. CD3 is gluten and lactose, do you know? And you can actually incrementally move towards a normal diet, creep by creep. You might even be able to do that in the same cohort of children or the same cohort of patients if you use calprotectin as a marker as you introduce different things. So we're certainly in the process of discussing what comes next, because we've finished recruiting to the open label study. And one of the things we as a team, I mentioned how big the team is earlier, need to think about is, what are we going to do next? Where are we going to go next with CD treat?
Do you think you would have had a similar benefit if everyone just had like the classic Mediterranean diet, but didn't have any refined foods? It was all minimally processed.
Well, you're touching on two different things here, James. One's Mediterranean diet and one's about ultra-processed food and food additives. So I'll start with the second bit. So one of the things which is very interesting is that there's a lot of animal data to suggest that food additives are bad. But when we treat children with active Crohn disease with this liquid diet, we give them a lot of these food additives.
Like emulsifiers?
Yep. So we give them maltodextrins, which is not emulsifier per se, but we give them carboxymethylcellulose, which is emulsifier. We give them carrageenans. We give them polysorbate 80. So one of the things that we learned a lot working with Richard and the team in general is that preclinical data in animals does not translate to human disease recommendations, particularly when you can actually treat active disease with these food additives. So if anything, they can be beneficial.
So are these food additives something to be concerned about from a gut health perspective?
It's a very difficult question to answer because there are tens of thousands of different food additives, okay? So at the moment, we have studied 5-6 of them, and we make a lot of fuss about them. So I can certainly tell you that the ones that we certainly think are bad for Crohn's disease most likely aren't, because all of them are included in the composition of the feeds that we use to treat children with active Crohn's disease. But there are 1,000 others that we haven't tested yet. So yeah, this is an interesting area of research to pursue in the future, but I think we have to do it within a very careful way. It's very important for us to understand mechanisms of action using animal models, but it's totally wrong to develop data recommendations from animal experiments. And this is a mistake that we keep on doing all the time, because now there are...
Well, we don't.
No, not as Richard and Costas, but... Societies do that, actually. There are actually quite a lot of the recommendations out there about what patients with Crohn's disease and ulcerative colitis should consume or not are based on preclinical animal-based data, which in our opinion is wrong.
One of the smartest papers that I think you've been responsible for putting together in recent years, Costas, was one where you took that concept, you said, okay, these are all the foods that we've been associated or linked with Crohn's disease as being important. But actually, let's look at all the formulas that are used to publish on as successful treatments for Crohn's disease and exclusive enteral nutrition. And let's look at the ingredients list. And let's look at these, I think 61, wasn't it?
61 feeds,
Feeds.
Products.
And all the different components that are present within those feeds. And if they're there and that feed's successful in treating Crohn's disease, then... It makes it less likely, right? That's a driver of inflammation or part of the pathogenesis story. So I think one of the things we have to be a bit careful with, James, when we're talking around this is whether we're talking specifically about Crohn's disease and management of Crohn's disease, whether we're talking in more general terms about everyone's diet, and what we're trying to get at here and what recommendations we're making or endorsing. I think another thing that the community, if I can say that, often get a bit confused about is that when we're talking about CD treat or exclusive enteral nutrition or any of these therapies for Crohn's disease, we're talking very specifically about someone who has active Crohn's disease that we're trying to switch off the inflammation and heal their bowel. That's a very particular phase and a very particular action to try and achieve that. I think there are probably different phases where someone who doesn't have Crohn's disease develops Crohn's disease and what things are important there on that journey. And also people who have got Crohn's disease who are in remission to try and maintain that and retain remission might well be very different again. And actually that breaking out those 4 different ideas. Healthy people, what do they eat? People who don't want to develop Crohn's disease, what do they eat? People who've got Crohn's that's active who want to go into remission, what do they eat? And people who've got Crohn's in remission, how do they stay there? Are all very different. shows you how complicated the whole thing is.
And this brings me on perfectly to one of the things we really wanted to discuss, which is personalised dietary interventions, personalised nutrition and so on. So could it be that whatever the driver is for Crohn's disease, from a dietary perspective, if we assume there is one, given that when you kind of change the diet drastically, you get a reduction in inflammation, could it be that it's common across lots of different autoimmune diseases? Like in your field, ulcerative colitis, systemic autoimmune disease, has it been driven by the gut, and is it diet that's driving these conditions, do you think?
I mean, one of the things that's probably surprising is how little exclusive enteral nutrition has been trialled in different inflammatory conditions.
Right.
That's right.
There's, people always say it doesn't work in ulcerative colitis, but there's really, really little looked at it. There's one study very recently that a lot of people have been excited about that came from India that showed that if you have people with acute severe colitis, the worst form of ulcerative colitis, and you give them, I think it was a week of exclusive enteral nutrition in addition to standard therapy, those patients tend to do better. But it's quite a big ask actually, because you've got someone who's profoundly sick, who you're putting on IV steroids, which are an appetent stimulant, and then you're giving them a liquid-only diet. It's a big ask, but actually incremental gains in that particular condition are important. So I think there might well be a vogue towards trialling these things a bit more as we move forward, particularly as we start accessing more acceptable forms of dietary therapy. So if CD-treat becomes, a therapeutic option, which I hope it will, then actually being able to offer people a solid food diet in that context, rather than saying we're going to put you on a liquid diet for 8 weeks, it means that you can test and try these things more in that setting.
Because some people swear by this carnivore diet where they only eat meat for a period of time and their psoriasis goes away, just as an example.
Yeah.
And maybe there's some parallels there between the carnivore-only diet and, meat-only diet and what you're talking about, as far as there's no fibre.
It's pretty low fibre, yeah.
Yeah, the carnivore diet is pretty low fiber, but it's also pretty low in carbohydrates. But it's not the case for the liquid diet, because the liquid diet is low in fiber, but it's pretty high on carbohydrates. So I don't think they're synonym, kind of like diets. EN has been used with some success also in children with arthritis.
Right.
Yeah, so there are a couple of studies published, I think, in Scandinavia, where children who had juvenile idiopathic arthritis were given EN for 8 weeks, and the authors observed improvements in inflammatory markers in blood. We are in the process of doing a study here in Glasgow with adult patients with rheumatoid arthritis, where they will be offered exclusive enteral nutrition. You don't know about that, right?
No, I don't know about that. It's a
Sorry.
bombshell.
I get really excited though when you're talking about this.
So the reason we use EN is because one of the unique characteristics of exclusive enteral nutrition is that this diet is a diet which is free in fiber. And normally it's almost impossible to produce a diet which is free in fiber. Even with CD-treat that we aim to reduce fiber as close as possible to the EN levels, it's almost impossible to bring it down to zero.
Yep.
So we think that in these conditions, EN most likely works because it doesn't provide fiber to bacteria. So essentially the bacteria are undergoing kind of like a status of fiber starvation.
Is it fair to say that if you're healthy, fibre is probably good, but if you've got acute inflammation in your gut, maybe systemically fibre might not be good? And if so, why would that be?
Well, there is a paper recently published by the Canadian group in Edmonton, which shows exactly what you said. So they say that if you have no inflamed gut, fibre may be good for you. But if you undergo a major inflammatory response, then this fiber actually may cause more inflammation, mainly because you don't have the right type of bacteria to break down this fiber and produce this beneficial short-chain fatty acids. So again, going back to this idea that Richard mentioned, that the same nutrients may play a different role in disease etiology, in management of active disease, and maintenance of remission.
So what I say to my patients now when I give them a course of exclusive enteral nutrition is it feeds the human, but it starves the bacteria.
Yeah.
And I might have said that to you before in episode 1, I'm not sure.
I think you may have,
But I think that concept is quite a good one, because you're giving nutrition to the host, but actually you're reducing available substrate distally. And I think that's probably what's underpinning the paradoxical finding that Costas identified all those years ago, that that you are diminishing everything, you are making everything worse, but you're actually also reducing activity of these key organisms that might be important in driving inflammation.
My brain's sort of jumping ahead a little bit, and I'm thinking, is there not maybe a third or a second paradox here, which is that for some reason you add in a ton of diversity with an FMT.
Yeah.
And you, in some diseases, are having quite a profound impact. Inflammatory conditions I'm thinking of, right? So how might that be?
So C. diff is the kind of ultimate FMT therapeutic option, I suppose. It's the place where we've got nice recommendations now to support FMT, right? Which Absolutely. I think has been a bit of a game changer probably, and has certainly increased the public's appetite for FMT as a potential therapy. I'm sure you've seen that or come across that.
Definitely.
But C. diff is a relatively straightforward form of dysbiosis, if we use that word, where you've got overgrowth of one particular pathogenic organism, and then once you throw competitors into the mix, it seems to just give up and go home. Do you know? And I don't think that treating C. diff is all that complicated, which is why I think FMT works very well there. There's relatively little, and it's very patchy about FMT and Crohn's disease, and I kind of understand why, because Crohn's is such a heterogeneous condition that it's hard to know how and when you're choosing for that, and I suspect people are more anxious about it because of the possibilities of fistulas and strictures and things, you know, whereas it's used more in ulcerative colitis with relatively consistent signal. There's one or two now that have come out that have kind of said there's not a great signal here, but relatively consistent signal, but probably not a maintained signal. And one of the questions is, how do we identify who's going to benefit? How do we match that to them in a way that makes sure that they benefit maximally for that, and how do we maintain that? And I think those are important questions going forward there. I've always thought that Crohn's, this is quite crude and I don't really have data to back it up, but it's how I've thought about this for a long time, that Crohn's is to some extent the presence of some bad guys that cause inflammation, and so that's why reductive therapies like EEN work. And ulcerative colitis is the opposite, is the absence of organisms that contribute something to function, whether that's butyrate production or whatever, you know, that there's something there that's missing that the host needs. So when you give an additive therapy to ulcerative colitis, you're helping to give that back. For whatever reason, it's not maintained, and that falls back down to baseline again, but there must be a way to address that seesaw and to fix that by adding over here, and to fix that by taking away over here on a permanent basis or replacing. And I think, and we've talked about this before, I think there might well be ways to do FMT successfully in Crohn's disease, but I think just battering it in there and expecting it to work is too simplistic. I think we need to be cleverer than that. And I think as we go forward with microbial therapies in these conditions, we need to start thinking about what are we trying to achieve and what's the best way to do that. How do we set the scene so that the FMT or whatever colonizing therapy we're going to use here is most successful and actually gets a chance to do it. And that might be things like pre-treatment with antibiotics. I always go back to
quite popular.
I always go back to the sort of cancer model, which is, you know, you don't just do a course of chemotherapy. You know, there's a plan from the outset about how, you know, where what is this tumor, where is it, how are we going to address this, and there's a combination often of three things: radiotherapy, you know, well, surgery, radiotherapy, and chemotherapy, depending on the cancer. I'm not a cancer expert. I have to be careful now because I'm going to go say something that's wrong, right? In 2023, immunotherapy, right?
Immunotherapy.
But all these different therapies come together to achieve a longer term goal, and hitting something really intensely at the beginning, knowing that you're going to achieve something long term is worth doing. And I don't think we've got there yet in IBD, but I think we probably will go there. I think that's where the field's moving. Sorry.
Now that brings me back to personalised dietary intervention.
Yeah, so it's a big thing. A lot of patients pay a lot of money to small biotechs and companies and startups to get their
need
personal...
to get you a lawyer before we answer this question.
No, I mean, I don't need a lawyer. The SPAGAN position paper has just been published.
What is SPAGAN, sorry?
SPAGAN is the European Society of Paediatric Gastroenterology, Hepatology and Nutrition, and I was leading a position paper which is all about precision nutritional therapy in pediatric IBD. So there's a lot of interest at the moment among healthcare professionals, scientists, and patients themselves about trying to personalize their nutrition. So essentially, there's this concept that different people respond to to food differently based on their microbiome, their genetic makeup, their immunophenotype. As a concept, this is pretty cool, and most of the evidence we have at the moment is based pretty much on association studies. So when we looked at the literature to see whether we can make any strong recommendation about precision nutritional therapy in inflammatory bowel disease, we found zero. Okay, none. Okay,
wow.
So
I mean, there are companies.
Well, companies still sell their services across Europe. We're not going to go much in detail about that. But when it comes to making recommendations on what type of diet you have to follow based on microbiome, we have absolutely no data. We've got some data about kind of like treatment stratification when it comes to the use of exclusive enteral nutrition. For example, there is some data to suggest that, depending on your disease phenotype, EEN may work or not. We've got very, very little data to suggest that certain kind of like people with a certain polymorphism with regards to how your body metabolizes long-chain fatty acid may be at increased risk of developing ulcerative colitis and Crohn's disease, but all of these studies have to be confirmed within clinical trials. But the kind of like the short answer to your question is at the moment we're not in a position to make any recommendation for precision nutritional therapy, at least in IBD. I'm not talking about other kind of like non-communicable conditions, but certainly not for IBD.
Now, there are a variety of companies offering what they call at-home microbiome testing.
Mm-hmm.
And some of them claim to be able to give you recommendations around what to do next in terms of food you should avoid, food you should start eating, so on and so on. It sounds like, and I'm not talking specific about any one company per se, but it sounds like we're maybe not quite there yet in terms of being able to action a report like that.
In the context of IBD, certainly we're not there. I don't know, what is your...
I think you can go further than that probably, and I think this goes back to question one. Tell me what healthy is. So if you want to set up a service where you charge people money to tell them what healthy looks like and to give them recommendations on that, first tell me what healthy is and show me the data that you've used to define healthy, and also show me the data that you've used to define the recommendations that you're making to people about what they should change based on what you've identified. And show me the robustness of your methodology, that if you take a poo and put it in a pot and post it somewhere, and then that goes through all your various methods, that's actually robust. And if you did the same thing, taking it immediately to the lab or putting it straight into a -80 or, all the various things that you can do that, lots of people have done, and not least Costas here, to actually try and validate methodologies in the lab. Show me that that's all robust as well. And once you've done all that, then I'd be happy to support your product and endorse that and recommend that. But right now, I get asked these a few times a year. Actually, someone will bring me a big fancy report that they've paid quite a lot of money for and say, can you help me with this? And I would love to be able to help them with it. And I usually say, I wish you'd asked me first, because I would have said not to spend money on that and not to go there, because I don't know what it means.
And this is as someone who's both a clinician and specific scientific training and significant personal and professional interest in the field.
Yeah.
And if you can't give someone...
I think I know a reasonable amount about what this report should mean or what it should be telling me if I'm a patient, And actually, when it comes to... I see it a couple of times. I see it in people who don't have inflammatory bowel disease but who have other gut-related symptoms looking for an answer, and I understand that, I completely understand looking for an answer. It's literally what I do for a job.
Right.
And I see it in people who've got inflammatory bowel disease trying to help guide therapy or choices for therapy. But it genuinely doesn't give me anything new to bring to that patient's journey or to offer them. And I generally recommend people don't go down that path. Now, that's not to say that won't emerge as a new thing going forward, and I really hope it does.
It could, right?
Yeah. Actually, I'm thinking I'm right in saying this, there's not a single microbiome diagnostic test available yet, beyond doing a stool for E. coli and knowing,
Yeah,
you know,
or
like
C. diff.
that's pretty crude, isn't it? But you can't. Nobody has yet developed or validated a microbiome diagnostic test that's useful, either in terms of confirming a diagnosis or prognosticating an outcome for somebody. There's lots of interest in this, and one of the things that we've done, and we did definitely talk about this in episode 1, because I know you've snapshotted it and made me a machine learning expert, is how we use machine learning and tools like that to try and predict something.
Yes.
But that's actually one of the funny things about that is we don't really do that believing that that's the direction of where that's going. We use that as a scientific tool to interrogate a question or a binary outcome. Yeah. So you might say, can you show me Crohn's versus non-Crohn's? Can you show me responders to treatment versus non-responders to treatment? So that we try to understand the biology that underpins that. We're not actually saying, can this machine learning predict this so that we can generate this as a test and sell this on the market? That's a totally different concept. And actually, by the time you've done that, just do a cat protectin is much cheaper. Do you know, if you're actually asking a question about whether someone has or hasn't, you know what I mean? Like there's other tests that are available. And
we have also to think about the implications of all this recommendation about nutritional therapy, people avoiding food additives based on animal models. You know, patients with IBD restrict the diet anyway. Sadly, we tell them that, you know, they need to follow a certain type of diet to get better. We tell them that all these ultra-processed foods and food additives are bad. So actually, you know, we drive them really nuts because they restrict the diet anyway because they feel that, as you told us, gluten, dairy products, and fiber are bad. Now we tell them that food additives are bad as well. And now we tell them that there's actually a certain diet they have to follow. So we have to think a little bit about the implications of making this recommendation for patient care and their well-being in overall.
What's fascinating for me listening to you talk about your work is that it sounds like you actually maybe don't need personalised dietary interventions for people with acute inflammation, because you've got this excellent tool, notwithstanding limitations, liquid diet. But it seems to work, and more adults could try it. And the thing that gets me most excited is it's essentially not correlative evidence, it's causation, right? You're drastically changing what's going into the gut.
Yeah.
And as a result, you're having significant local effects in the gut, but also potentially systemic. And there are people, and I come across them all the time in my capacity, because I'm not immersed in, I guess, academic circles all the time, in clinical circles all the time, where I think you've probably got a higher proportion of believers. I'm up against people who say things like, "No, the microbiome's not important."
Yeah, I mean,
seriously,
we have to be careful because the fact that the EN changed the microbiome does not prove any causation. Okay, bacteria can change because you just give them a diet which is free in fiber, but certainly the fact that extracerebral nutrition changes certain species that we think that are important, okay, and they actually change in a different way, help us to understand that these guys are not very important in the disease management. But for us to be able to prove causation, we need to run these well-designed randomized controlled trials, while essentially we try to manipulate the bacteria that we think are important for the disease course and see what's going to happen in patients' outcomes.
It's really interesting because this is a big weakness of dietary therapy across the board, and this comes up from time to time, you know, when people are trying to make recommendations about diet and where it sits in guidelines and things. It's like, yeah, but you don't really have a placebo randomized control trial.
For diet?
Yeah. Yeah.
Because people would die.
People would die pretty quickly, actually. So the mortality on one side of that would be very strong.
Yeah,
but actually, it's very hard. So people get around that by doing a randomized trial against something else, do you know? So there's a paper published that compares specific carbohydrate diet against Mediterranean diet and gastroenterology. Our Canadian and Israeli counterparts really developed a diet called CDED, Crohn's disease exclusion diet, and they compared that against exclusive enteral nutrition. And we will probably with CDTreat take it down a randomized trial against something, but I don't think it's never going to be against placebo, because not giving people food is not an option. And
Absolutely.
actually, ethically, there's this concept called equipoise, which says that you need to kind of have enough uncertainty about your ultimate outcome that it's reasonable ethically to do what you propose. That you don't really have equipoise that giving people with active Crohn's disease a normal diet is a reasonable thing to do. It wouldn't be fair to do that to people, to say, oh, actually, why don't you just spend 2 months on a normal diet with your Crohn's staying bad and getting worse, whilst this other group get a therapy that we think will work. So it does make it very difficult, and it's a hard hurdle to overcome. I suppose how we've addressed that till now, and our studies have been open label, and one of the open label means that everybody knows what the person's getting. So if I was going to give you penicillin, you would know it was penicillin, and you would know that you were getting it because I was trying to treat an infection. So when people get CD treat, they get it knowing they have Crohn's disease, knowing they have active inflammation, and knowing that this is a diet that we presume will make them better. And of course, you'll have heard of, I know you trained doctors, so you've definitely heard of this, but I'm sure most of your viewers will have heard, and listeners and viewers will have heard of the placebo effect, which can be quite strong when you give someone a sense of suggestion that something's going to work for them or might work for them, that actually they would get a benefit just from putting themselves into that mental place. Or there's a lot of complexity about what that is and how that works. But can I just
add one point there, which is really fresh and new. There's been some preprint papers that have come out recently that suggest that the size of the placebo effect can correlate to, for example, you telling the patient that this is a higher dose versus a lower dose.
Yeah.
So it can sort of titrate up.
This is a higher dose of nothing.
Exactly.
Yeah.
Seriously. So there's some evidence there that suggests that the placebo effect has lots of different levels. And there's other aspects to it as well, like the care that comes around it, as you know, is a big thing, coming into the doctor's office, being sat down, all of that potentially could be a placebo. The quality of your clinician on the day,
and we inevitably use that in medicine, right? So if I was seeing you have you brought your child along who's got abdominal pain, and I say to you, well, I've got this therapy that I think we could try, but I'm not sure it's going to be very effective, but we could at least try it because, we're not losing anything, right? Versus saying to you, I've got this treatment, I think it's going to be the one that's going to help here, it's going to be useful. It's about, it starts at that very beginning. And actually, I think, I'm not good clinicians, but I think naturally clinicians will tend to use a bit of that in their practice about how they present things and how they, it's the marketing element of what we do. Of course, we look for science and we look for evidence and all those things, but we don't always have perfect therapies that work 100% with zero side effects. So we have to think about how we present them. What I was going to say was, with CD treat, we get around this by trying to look for objectivity. So we use calprotectin very heavily as a marker of inflammation. So it's a neutrophil degradation product. It's a protein that you can detect in the stool that comes from the presence of white blood cells within the gut lumen, if you like, the tunnel that is the gut. And so when it's there, it suggests inflammation. The more of it's there, the more inflammation. And so we use that to try and pivot on whether or not the therapy's worked or not.
That's right. Now, what would be the promise of personalised nutrition realised? If it did work, what would it look like in the future?
Wow, that's a difficult question, but the concept behind precision nutrition therapy or dietary therapy is that, we assess your microbiome, we kind of like group you in a certain category, and we say that based on this microbiome or based on this genetic makeup or all these different polymorphisms that you have in your genome, you should follow this diet. We actually are in the process, and probably Richard doesn't know much about that, but we are
more
trying,
secrets. I'm so disappointed.
No, sorry, this is work we do with our partners.
It's benefiting you in all sorts of ways.
You're learning a lot of things here today. So we have...
So what are you doing without me, Costas?
Have I told you about these sweat sensors?
Yes.
Okay. So basically,
this sounds cool.
Yeah. So this
sounds cool.
Yeah. Basically, there's a startup company in the University of Dallas in Texas, where they have developed these small kind of like wearable devices that can measure cytokines, which are inflammatory biomarkers in your sweat 24/7. So basically, this is pretty cool, and it's far too good to be true. But here the concept is that people are wearing these devices, so they're able essentially to monitor their inflammatory markers 24/7. They consume food that they would normally consume, and then if they see, for example, that some of these inflammatory cytokines increase, it means that most likely that this food is a trigger of the condition. They try to avoid consuming this food and try to see if these cytokines will go back to the baseline.
And are these cytokines sweat soluble, sweat stable?
They are measured in sweat. Now, how exactly they're measured, I don't know much about that because everything is obviously proprietary and you understand that. But we are measuring 4 different cytokines, and all of these cytokines that we measure have high relevance to Crohn's disease. So yes, we're doing at the moment a trial which is called the CYPENS, where we try essentially to correlate the changes in these sweat cytokines against changes in fecal calprotectin, which is a well-established biomarker of gut inflammation. If this works, then it's going to be magic because people don't have to worry about their microbiome. They just eat whatever they eat.
We should talk about collaboration because I think Enterobiotics has potentially the largest sample repository from extensively phenotypically characterized healthy people, quote unquote, with pathogen screening on every single sample, with 16S sequencing on a lot of them. And we've now got a dietary questionnaire as well. And we look at the Bristol Stool Score, we look at weight, we look at everything else. You'd probably be able to tease something out of it in terms of what impact does a food have on stool, because we're testing them all anyways.
Sure, yeah.
And one thing we've not figured out yet is what does the ideal donor look like? And we have lots of thought experiments within the company around what would the optimal product be. We talk about diversity. We talk about the pro-inflammatory genuses. We talk about the quote-unquote anti-inflammatory genuses that have particular functional properties. And we try and do that blackboard experiment that you were talking about earlier and chalk up what do we want the product to be and is it the same in each indication? And because we rely on donations, the quality of the starting material, in effect, dictates the quality of the final product.
Sure.
So I'm now wondering, is there more we can do? Right?
Definitely.
Absolutely.
There could be. Now, to bring it back to the sweat, it's definitely an American company. I'm just trying to imagine raising money for that in Scotland. People would just be like, nah. But the US have a much more open mind to stuff that doesn't sound possible or stuff that sounds a bit off the beaten track. Is the thinking that you eat a lot of one particular food and you see lots of cytokines appear in the sweat, something like that?
Yes, I think that's the concept behind that. So
specific for Crohn's disease, though.
At the moment we're testing, I think we are testing this in the context of Crohn's disease and in children, but there are other studies in adults where essentially they try to see how these sweat sensors function in adult patients with Crohn's and colitis who receive biologics. So basically they try to see essentially whether changes in inflammatory markers in blood when patients receive biologics correlate with changes in these inflammatory cytokines in sweat. So there's a lot of kind of like development science at the moment. But if this technology works, I think it's going to be quite exciting. We presented our kind of like preliminary data, not ourselves, our partners in the States, and it attracted a lot of interest from media in the States about this technology, this idea. And the other thing you have to remember about that is that everything is done in a very passive way.
Yeah.
So you don't have to impute any data. You just wear these patches. You carry on your normal lifestyle. And then, you eat whatever you want to eat. You are exposed to the stress that you normally you're exposed. And then you try to see essentially how all these environmental factors, including your diet, influence your inflammation in the gut as this is reflected on your sweat cytokine levels.
Now, on the precision personalized side of things, how impactful is it really going to be? Because it strikes me as though the sort of baseline dietary recommendations that we give to people are probably going to stay constant so long as we're humans, right? So eat like a variety of fruits and vegetables, get 20 grams, 30 grams. If you can get more, assuming you don't have acute inflammation, fiber per day. High micronutrient content, minimally processed foods. Spoke about the Mediterranean diet, but maybe that's something different.
Yeah, I think Mediterranean diet is pretty cool, and I like it because I come from a Mediterranean country, and whatever supports my country, that's good news. I think there's no doubt that Mediterranean diet is very good for several aspects of your health, and there's no data to suggest at the moment that the Mediterranean diet can be bad if you've got Crohn's disease. Particularly, there's no data to suggest that the Mediterranean diet can be good if you've got active Crohn's disease. So,
is that right?
Yeah. So the study that Richard mentioned previously, which is called the DINE-CT study, is the largest RCT where the authors compared Mediterranean diet against another exclusion diet, which is called specific carbohydrate diet. So in terms of symptoms improvement, both diets work the same, but as Richard mentioned earlier, hardly any of these patients had active inflammation in their gut.
When you look at the calprotectin results in that study, they're interesting.
Like that, less than 20% of them had active inflammation. But what was really important also for this study is that even in the small subset of patients who had active inflammation, Mediterranean diet did not improve their inflammatory markers. Okay.
Was it a proper Mediterranean diet?
Well, that's a very good question. So what is a proper Mediterranean diet?
Yeah, what does that mean?
That's what I'm trying to get to, because for you as a man from the Mediterranean, it might be slightly different to.
But you're a Greek man from the Mediterranean. The Italians would say something slightly different.
But in my opinion, I don't think it's just the matter of Mediterranean diet. It's the Mediterranean lifestyle, which is
sun.
Yeah, it's sun. It's a lot of leisure, kind of like physical activity, less stress. Back in the day. Different type of stress. People are not worried about social media. They're worried about, for example, if they've had enough food to make it through the year. A lot of religious fasting. Okay, so people go,
really?
Oh yes, a lot. So if you follow, for example, the Greek Orthodox Church, you are on one of these religious fasting kind of like regimes for half of the year. So there are quite a lot of different things that you have to take into account into the Mediterranean lifestyle. So now people are moving away from the Mediterranean diet to the Mediterranean way of living.
Yeah. How important is olive oil, do you think?
Yeah, I think it's very important, but listen, olive oil is good. I don't think it's much bad about it, particularly when you compare it with other type of processed oils. I think it's by far superior. But the amount of the olive oil that people consume in this Mediterranean area, or they used to consume, is pretty insane. So my parents produce. My parents produce olive oil themselves, and they produce something like 120 liters a year, and they consume it all.
Spoken to someone about this.
Yeah. So my mom cooks food.
Volumes.
Yes. So my mom boils beans in olive oil.
Is that right?
Yeah, a lot of olive oil. Like insane amounts of olive oil.
So what does the Mediterranean diet actually mean then? Just to kind of summarize it and wrap it up. And
very little animal food, okay? So back in the day when people used to be poor in Greece, okay? So they didn't have a lot of animal protein to consume. They didn't have a lot of poultries. They didn't have a lot of meat. So they would consume mostly pulses, legumes, cereals, dairy products, stuff like yogurt and milk. And my mom would tell me that they would eat meat twice a year, every Christmas pretty much, and because they were very poor. So they had 5 goats and 6, hen, and they would use the hen to get eggs. So they would eat a lot of eggs, but they wouldn't slaughter the eggs because they need the eggs to lay eggs. And they had goats that they would milk to make cheese.
Yeah.
And they would slaughter a goat every Christmas and every Easter, and they would eat everything.
The whole lot.
Yes, that's it. Yeah, the whole thing. So they didn't consume a lot of animal products. I'm talking about meat. Sorry, they could consume a lot of fresh vegetables. A lot of the food that they could consume would be fried. So they would fry vegetables and aubergines and
in olive oil.
Always in olive oil, yeah. And not because that was the healthiest option, it's because this is what they could use. This is what they had.
But it turns out it is it the healthiest oil in your opinion as an expert?
Yes, I think it is among the healthiest oils. Yeah, it has the right amounts of antioxidants. It comes with a lot of phenols and flavonoids, which are meant to be good for your health. And it's not processed. It's naturally kind of like produced.
One of the questions I get the most from members of the audience is, should I eat this? Should I eat that? And it can be very specific. I did a talk in Dumfries earlier in the year as part of this stargazing trip, which I, by the way, highly recommend. And part of the gig was, James, you do an hour-long talk. I met the owners on a plane and we got chatting. He said, you do an hour-long talk and you and your sister can come stargazing. Fine, absolutely. And I pitched it, what I thought at the kind of level. Turned out that the whole of Dumfries and Galloway and Cucubra, I think the city's called, the town's called, were there. Yoga club were there. Lots of patients were there. And they were prepared, really prepared. And I was getting questions like,
pitchforks kind of prepared.
No, as in notes and paper, and it was brilliant. It was fantastic. The Q&A went on for absolutely ages. But they asked me some really hard questions about some things I'd never even heard of before. Like, is the stalk of the dandelion good or bad for the microbiome? I read on this book, and I was just like, what was it? So it's really difficult, isn't it, to respond to say, is this one thing good or bad? Because it's usually all context. But if I was to ask you both as experts working in the field, could you try and construct a diet which was beneficial for the broadest range of microbiota and therefore the broadest range of the population? What would it look like?
And we're trying to do that already a little bit in something we call UC Treat. Would you like to talk about that?
Yeah, maybe.
Yeah.
Not too much.
Not too much.
Yeah.
Okay.
Yeah, so we try to do that. I think the short answer to your question, James, is it's a plant-based diet which has a lot of color.
I like it.
Yeah, it's a colorful plant-based diet with a lot of fermented foods as well.
Yep.
So there's a lot of interest about, for example, about how fermentation as a process influences your gut microbiome and the host by extension.
Fermented foods has nearly fallen out of the British and American Western diet. There are still countries that rely on fermented foods a little bit, Germany, sauerkraut being an example,
right.
Korea with kimchi.
Yep.
But actually they've fallen out a lot of our countries, and they're a really important source of particular types of microbes that you don't necessarily get elsewhere. So I think fermented foods would be something to put back into the diet if we were to do that. Which one to choose is open for debate.
Yeah, because there are different fermentation processes as well. So you've got the lactic acid bacteria, which produce a lot of lactic acid, like in dairy products. But then, for example, certain type of cheeses are also fermented products. But then there you don't have lactic acid production. You've got propionic acid production, which again is a different fermentation, kind of like...
so more than one's probably the answer.
Yeah, it's more than one.
High fiber's probably the answer.
Could I push you a little bit more on this? Because some of the listeners have listened to every single episode, so they've heard people coming on to talk about particular types of fermentation processes, amounts of fiber, for example, and different types of fiber. So could we go a little bit deeper, perhaps, on different types of fiber and different types of fiber sources? Yeah,
different types of fiber have different effects on your gut microbiome. Different types of fiber produce different bacterial metabolites. For example, the resistant starch produces mainly butyrate. And you get that, for example, if you take your pasta or your potatoes and you put them in the fridge and you take them out, so this increases the amount of resistant starch, which is essentially the amount of the starch which is not digested and absorbed in the upper part of your digestive tract, essentially your small bowel, and goes down to your colon and is fermented by the bacteria. So resistant starch in general produce more butyrate. On the other hand, other fibers like, for example, pectin, that you get it from apples, tends to produce more acetate. And then again, you've got different types of fibers like inulin or all these fructooligosaccharides that you get them from, let's say, from leeks, from onions, from artichokes. Again, they mainly produce more butyrate. So not all fibers obviously have the same effects on the gut microbiome. There are certain fibers which can be fermented by certain bacteria, and others which can be fermented from a broader kind of like group of microorganisms. But at the moment, and some of them which are not fermented at all. Okay, for example, cellulose is not a fiber which is fermented much. there are certain species which can break down cellulose, but again, in our labs, when we use in vitro kind of like simulants of the human gut, we see that actually you don't get a lot of microbial activity going on when you feed gut microorganism with cellulose or other type of fibers.
And is it your view, as experts, you should just try and get a really broad range of all the foods that you mentioned, or should you try and focus on, for example, inulin or pectin, or would that be verging on the precision personalised approach that we were talking about?
You'd probably be better off eating a variety of fruits and vegetables rather than eating a set amount of fibre from one source or one or two sources. Probably.
Yes, because you keep all guys happy.
Yeah.
Keep all of them happy.
Yeah, because...
So why do we not have, because we know it's difficult for some people to eat lots of fruit and veg, and I hear people talking now about 30 different types per week versus 5 a day. So you get an even broader selection. But that's difficult.
It's very expensive as well.
It's expensive, and for some reason in Glasgow we don't do so well in that department. I mean, I don't know how many people are cooking in olive oil here, eating legumes and...
Yeah, olive oil will not have major effects on your gut microbiome, but I don't necessarily agree that eating a colorful plant-based diet is expensive. I will totally disagree with that.
So can we have that debate then?
Yeah, I think you can have, cheap fruit and vegetables. You can eat a lot of apples, a lot of carrots, a lot of broccoli, a lot of lentils, a lot of oats. And I hope you agree with me that none of these plant-based foods are very, very expensive. They need time to cook them and prepare them. And of course, we live in an environment of convenience where people prefer to eat ready-to-use meals. But I would totally disagree that healthy, good food is expensive.
I think we're getting on a societal, almost political question, which is probably not our expertise, but I suppose I would come back to say I think there are a lot of things that make food and food preparation expensive and challenging within society that are not just about the cost of a raw carrot, So yes, you could take a carrot or an apple and you could wash or peel those and eat those as they are, but actually to make a meal from them from scratch requires knowledge, requires the ability requires the pots and pans and things that you need, that endless copious volumes of olive oil, as we've heard, and the knowledge and time to actually apply to that, which all of those things factor into cost, which might not just be an economic cost, and actually I think our society has gone quite a long way away from cooking things based on, you talked about processed foods, ultra processed foods. I saw a thing about estimates of ultra processed foods being up to 40% of our diet, and it might even be higher in some cases than that. And actually, I was speaking to a medical student about this last week and saying, just go walking around your favorite supermarket. I will not tell you any particular brand here, but go around your favorite supermarket and just look at the shelves and try and decide which of those things are whole foods and not ultra processed, and you'll be amazed, because even the things like the bread are ultra processed. Absolutely. And actually it's so endemic now in life that I think we've moved really far away from whole food based diet where we cook things from scratch. And yes, I think you're right, Costas. I think it is possible to do these things inexpensively if you start from a baseline where you have everything you need to do that. Right. But actually, if you don't start from that baseline, it's a really hard hurdle to overcome versus grabbing something you can stick in the oven and it'll be ready in 10 minutes or in the microwave.
I mean, what we've talked about in this podcast before is, was this created by man or was it created by God? Believe in God as you wish or don't, but it was more like, can you pull this out of the ground?
Yeah.
Or can you not? And generally the advice we hear, people keep coming on and saying again and again, if it is minimally processed, it's likely to be better than if it's been through levels of processing for the gut and also for your wider body, right?
Yeah.
But James, we don't really know that because there are very, very few clinical trials which show that eating a lot, I don't even know any trial which shows that if you eat a lot of ultra-processed food, this can affect your microbiome in a negative way. But most important, this change in the microbiome can affect the host in a negative way.
No, and that's fair.
This gets us onto microbiome and obesity and some of the other interesting things we were going to take. That is a fair comment, but could you actually do that study? Is it ethical to do that study when you can correlate ultra-processed foods with a variety of health parameters?
Well, this comes back to your concept of precision nutrition. Actually, to me, precision nutrition is all dependent on what is your outcome and how are you measuring it. you know?
Right.
So if your outcome is a reduction in obesity or weight loss, that's relatively straightforward and it's fairly short term. So you can say, do this diet, here's the things for you, we're going to look at your weight and we're going to reduce that down. But actually just by observing your diet for a period and thinking hard about it, that in itself might be enough to reduce your weight. And the same things we talked about the placebo effect earlier, you know? But actually if you're talking about precision diet based on your cardiovascular risk or your risk of colorectal cancer or other things that are longer term outcomes, how do you measure those and how do you know what are your parameters for success? I think that's a big challenge across that sphere, is about, you know, what is your outcome, how are you measuring it, what is the time frame on which you're measuring it, and what are your parameters for success, and how do you know these things are sustainable? One of the biggest challenges with any dietary therapy is sustainability. You know, whatever you do with diet, whether you ask somebody to go on a diet to lose weight or you ask them to go onto a specific diet and to change that, actually changing those things in a big, big way. And I'm sure you know a lot about that because I know you've done that personally. But, you know, trying to maintain those consistent changes and action them, not just for a few days, but for months on end.
Yeah, that's super hard, right?
Yeah.
But I've found, and others have found who I've spoken to, that when you actively try and eat for your microbiota, so you follow the principles that you've talked about, predominantly plant-based, lots of fruits and vegetables, cut down on maximally processed, minimally nutrient-dense foods, you just feel good. You feel good.
Yeah.
And therefore you keep doing it. And the cravings go as well, which I think is kind of fascinating. And I don't get sugar cravings anymore.
Well, if you're consuming a lot of sugar, you're not going to get this post-brandial sugar rushes. It's not surprising.
It just kind of goes. Now, on the peptin...
Paparazzi are going to catch you at a kebab shop at the weekend. You know that,
no. People who know I stick to it. I just love it. And then, as you know, at the company, we offer unlimited fruit and veg, and we have this greens powder in the fridge, and we have fresh pressed green juice, and usually juice is really bad because it's got very high sugar content, but this juice is like 2 or 3 grams per 100 ml or something like that. It's quite low, and it's just like really low sugar content fruit and veg that goes into it. Most people don't like the taste, but the taste grows on them over time, and I do believe there's some element of their microbes signaling up saying, you know, we like this and so on. So
you don't give them sugar, but you give them artificial sweeteners, right?
There's no artificial sweeteners. Okay. There's no. Well, I'd like to talk about that as well. There's no artificial sweetener in the juice. Yeah. And if it was, it would be stevia rather than aspartame. Yeah. Why has nobody created? It probably exists actually. Now that I'm saying that, a supplement that has inulin, pectin, the oligosaccharides, resistant starch, so that for people who struggle with the fruit and veg element, they just put a scoop in, it's a sachet or something like that.
I think there are supplements on the market you can buy about them, but I think it's not a good idea to isolate certain nutrients from this plant-based category, because we know fiber is very important, but when you consume, for example, this colorful variety of food, you consume a lot of flavonoids and phenolics, which themselves are very important also for gut health. They feed the microbes, and by extension may also improve host health.
Right.
But there are supplements in the market you can buy. I mean, some of the dietary interventions we do buy actually supplements from companies, and these are blends of different fibers. So
and flavonoids and polyphenols.
Not flavonoids as such. I don't know. I'm not sure how easy it is to do that, but definitely in the UK market there are blends of different fibers, mostly those which produce butyrate, like the ones we mentioned, like inulin or fructooligosaccharides. You can buy them.
Do either of you two take one of those supplements?
No. I take a multivitamin with iron, but I don't take anything like that, no.
Do you take a probiotic?
I got one, inulin. If you take a lot of inulin, you're not going to be happy.
And why is that?
Because inulin is fermented very quickly in your gut and produces a lot of gas.
Okay. So you might be happy, but other people wouldn't be.
Well, yes, it depends. Yeah.
What about the probiotics then? Do either of you two take a probiotic?
I don't think there's any benefit in taking a probiotic if your gut is okay. Like,
Just
I
buy
think the
Greek
time
yogurt.
to take a probiotic is when your gut is perturbed by something, whether that's a course of antibiotics or an intercurrent infection or something. That's the time to take a probiotic. And we've definitely talked about this before, about the availability of probiotics being based on pragmatism and things that survive rather than necessarily the right choice for filling an ecological niche or fulfilling a function. So no, I wouldn't really endorse taking a regular probiotic if everything's okay with you. One of the things I'm quite interested in is where individual bacteria come from. You know, so like if you were to change your diet dramatically, or you were to go taking inulin and you know, a supplement that was to support and promote bacteria, then you would naturally select for some of those bacteria increasing in populations within your gut, and maybe reduce other populations accordingly. But they kind of have to be there to start from. And actually, I'm fascinated by this question of particularly these really difficult, and you'll know this from the lab work, you know, in enterobiotics, these really difficult, fastidious, oxygen-sensitive organisms that just don't survive. You have to go to great lengths to keep them alive. How do we get these in the first place? Where do they come from? And, you know, I think there's an element of that as well, actually, when you make big changes to try and promote your microbiome without doing something dramatic like an FMT.
Right.
Can you select these from the environment? Do they come in on your foods, you know, or where do they come from, and how do you actually activate these populations when you do a change like that?
Should we discuss that? Because I think
I don't know the answer, but you know,
I have some thoughts. I think most of us have within their gut somewhere some of the bugs you're talking about.
Yeah, at really low levels.
Like the Faecalibacterium Prausnitzii, the Akkermansia mucipilia.
We've got them in high levels, not at low levels.
Yeah, those guys are at high levels.
If we're healthy, right?
Yeah.
We see that in all of our donors, actually.
Yeah.
There's a good group that are always there. But I think there's a almost infinite number of strains and species that could be in your gut. We've characterized what, like 1,000, 1,500 within the human microbiome, something like that. I think in most people they'll be there even if they're at a tiny level. And even if you take a sample of stool over a course of 100 days and you profiled a sample from every single one of them, you might not actually get to the point in the stool where you can pick them up.
Yeah.
Or they're at some point in the GI tract. And then if you change your diet, then maybe you can promote them, and then you find them in your sampling method. That would be my thoughts. I think they're there, it's just they're hard.
They're there in everyone, but they're just...
Most people,
very sporadic.
I mean, people have what they would call the core microbiome. So basically, your microbiome has a constant composition by pretty much 60-70% of species. If you go down to strain levels, then perhaps you've got more kind of like intra-individual variation. But then you've got these kind of like transient organisms which, you know, they change throughout your life. So your core microbiome may still be there, but then you may have some of them who go there, they colonize your gut in a transient manner, but then they disappear. And perhaps these are the ones which may actually come from your diet, you know, who go there, they're transient guys, guests, they stay for a while, your diet changes, and this organism changes as well.
So you can definitely understand that if you eat fermented foods, then you're going to bring bacteria in there that are different or that are maybe not. That makes sense.
Yeah.
But actually, if you're going to eat celery or whatever, does it have bacteria on it that actually are relevant to you? And, you know, who's looked at this across a range of foods? I don't think anyone's really done that. Looking at the presence or absence of bacteria within the foods themselves.
But it's not sterile, as you know, right?
No.
I mean, there's probably Pseudomonas on there. There's, you know, unwashed vegetables probably, right? And
don't know.
Do we want them in our gut?
But when it comes to fermented foods, it's not just the fact that you are consuming the culture which causes fermentation, but exactly, because, you know, these organisms break down the natural ingredients of a food that produce all these different kind of, like, people call them postbiotics, or the different kind of like derivatives of food digestion and the fermentation, which may be beneficial for health.
You mentioned at the start there were these pathobionts. Pathobionts. Is there a list of like commonly agreed, universally agreed bacteria which fall under that bucket?
Yes, there's 12. No, there isn't.
I think there was one discovered yesterday.
I was going to say there's 12. I'm going to name them. No, not really. And I think it changes. So the whole point in a pathobian, I suppose the definition of it is something that can do you harm in the right circumstances, but often doesn't, you know?
Right.
And E. coli is the one that people bring out all the time to say, look at E. coli. Some of them cause you to go into renal failure, and some of them are used as a probiotic. So, you know, it's the same species. And so even species level data doesn't tell you what's going on with E. coli.
Right.
You need more than that. You need to get to strain level data, and you probably also need to understand a little bit of the host and what circumstance that E. coli finds itself in.
It's fascinating.
A
lot of people that buy E. coli Nissel, I think that's what it's called, isn't it?
1917.
Yeah.
Yeah, it's probably don't realise that actually another E. coli 0157
Can kill you.
can kill you.
Yeah, there's not much a market for that. Nobody's selling that in the
1917,
supermarket.
yeah, they don't sell.
0157. It's not. Nobody's selling
No. Then 1917 is selling a lot in Germany. It's called Mutaflor, I think.
1917 relates to the First World War.
I know a lot about that. Let's not go into that.
No. So that's
The
how it gets the
strain
name.
was
1917.
1917 was used by Hitler, wasn't it?
Was it Hitler? I don't know, but it comes.
Did
from
Hitler
the
take a
first.
probiotic?
I think some of their soldiers had diarrhea, and they tried to treat diarrhea, infectious diarrhea, using the Nissel 1917, if I'm not mistaken. But
That's cool.
You know, don't get my word for granted. But yes, I think some of the.
that is one of the uses for.
But it does come from
probiotics, right?
It comes from the First World War, 1917. That's right, and it has got a role in Germany.
That's fascinating.
Yeah.
So what's coming next then for the field of the microbiome, in your opinion?
You want to go first?
You go first.
I go first. Okay. I would like to see microbial diagnostics in a way that are useful, that can be applied clinically. I think we've seen this in clinical medicine, in genetics, and particularly the advent of, you know, high throughput next generation sequencing, gene chips and things that mean that actually a lot of the really careful, deliberate clinical medicine of doing, you know, lactate and pyruvate and whatever, to try and understand someone's metabolic pathways to make a diagnosis, you know, is increasingly being replaced by, let's just do a chip that looks at everything for that person and their phenotype and answers the question, you know. And I would like to think that within the next 10 years, maybe when I come back for my next interview with you, that we will actually have microbiome-based investigations that are useful in clinical medicine, whether that's to predict response to a therapy or whether that's to make a diagnosis. So that would be really nice. I think we're a long way from that right now because the tools, there's no standardization of the process for a sample, and the tools that are applied to that sample in terms of the bioinformatics are very labour intensive and deliberate for that, and are based on cohorts rather than individuals. But it would be nice. And the second thing I would like to see is more development of microbial therapeutics into that space, about how we influence the microbiome. Did I just steal yours? Did I?
Yes, you did.
I'm sorry.
That's all right. You can talk about the non-dietary.
Well, yeah. I mean, yeah, go for it. Why don't you go there?
It's okay. I mean,
Can I just ask you one question, sorry, before we get on to you, Costas?
Yeah.
So if a company developed a test and they convinced you that their workflows were standardized and the analytical methods were state of the art, and they had a really lovely bioinformatics pipeline, and they said, we can tell you about diversity, we can tell you about this long list of pathobionts, we can tell you about short-chain fatty acid producers and what's there. We'll give you a full suite of pathogens or potential pathogens, which I think are slightly different to the pathobionts, just for the listener, right? Yeah, there's
every time they're there, they're bad, in essence.
Yeah. Would that be useful to give you this report? No, because if someone so
not yet.
Right. So patient.
What am I going to do with it?
Patient X comes in, and they've got a problem with their gut, and I guess you need to be more specific than that. And they've got a long list of pathobionts. They've got hardly any, if at all, of the short-chain fatty acid producers that we'd like to see in there. The diversity is low on, say, for example, Shannon index versus what we currently understand as being potentially healthy, like above 4, for example.
Okay.
Would that not be quite helpful? Could you not No, not helpful.
No, I don't think what you can do
What are you
about
gonna
that apart from asking them to eat more plant-based food.
Yeah.
Well, that would be a
That's
good,
it.
good start, right?
I mean, even
But could you have done that anyway?
Yeah. Do you have to measure the gut microbiome? We know that plant.
Probably. Yeah,
You know?
probably. Yeah.
Do you need a £500 test to tell you that?
How many would you see? Do you think you'd see any patients? No, you probably would. Just speaking out loud now. But if everybody ate the ideal diet,
Yeah. Would I see any patients at all? Would I be unemployed? Is that the question?
if everybody actually looked after their microbiome in an amazingly rigorous and robust way, surely there'd be less patients in the hospitals.
Yeah, there might well be. I don't know how much IBD we would see. That would be a really interesting question, is if you took a cohort of people at risk of IBD and you treated them from a dietary perspective from very, very early in life to promote the healthiest microbiome you can, what would that do to the risk of subsequent IBD? I suspect some of them would still develop it, but probably fewer. It's a thought experiment and I don't have any data to support that. I think things like celiac disease would probably still happen. Mm-hmm. I would still occasionally see peptic ulcers and things because people would still get Helicobacter pylori. So there's another kind of different microbiome mediated disease. A lot of what we do in liver diseases would still happen, I suppose. So I would still have a job, but I wouldn't be as active with an inflammatory bowel disease as I probably am. I suspect, but I don't know.
Assuming that all this, assuming that diet interacts with the microbiome and this interaction gives you Crohn's disease, that this is
That's still not proven.
Yeah, it's a speculation, but we haven't actually proven that.
You feel very strongly about it, though.
Yeah, I think IBD probably is the first microbiome associated disease. You know, the way I think of IBD probably now is that it's a disease of the microbiome that happens to affect the human. You know.
Wow. Never heard it put like that before. We're going to cut that one.
Yeah.
Absolutely. I really like that. Yeah.
You make his day.
That's it.
That's cool.
Yeah.
That's cool. What do we need to do to prove it? So that there's no doubt anymore. I mean, I think CD3 is proof. Sorry to say. I mean, maybe I'm being overly simplistic.
Well, CD3 is a diverse diet. So the difference between CD3 and EN is that when you treat patients with EN, you just give them one food. And this is the food they consume always. When it comes to CD3, is you give them a variety of foods. And personally, I believe that there are certain foods of these which have an important role in causing inflammation and other ones which are probably protective. So, you know, in my opinion, in the future, what we need to do, we need to refine the composition of CD3 and try to work out which of these foods we don't have to worry at all, and we can actually relax the diet, and which of these foods we have to pay more attention and be a bit more kind of like restrictive or stringent in the amount or the type of the food we give them, I think.
The most interesting thing, and why I'm fascinated by dietary therapy and Crohn's disease, the most interesting thing for me is that you take someone who's got an inflammatory condition and active visible ulcers that you can go and see and count if you wanted to, that are bleeding and causing diarrhea and all these other things, and you do nothing to their immune system. You don't give them steroids, you don't give them potent immunosuppressant drugs, you don't give them anything to do anything to the immune system. All you do is just remove a whole load of things from their diet and give them these therapies. And you know that 4 out of 5 of them will get better and will heal all of that, and those ulcers will go away and the immune system stops causing the trouble that it's causing. And that to me tells me that we don't understand this disease in a fundamental way, and that there's something we can unlock here which will transform the management of this disease for our patients. And that's where I really hope we'll go with, you know, CD-treat and things past CD-treat, is how do we actually take somebody on a dietary journey for this condition rather than on a drug-based immunosuppressant journey. That's not to say, and this is important to qualify as a practicing physician, the drugs we have for managing Crohn's disease and ulcerative colitis are very good drugs and they're needed. And I would far rather choose to use those drugs to switch off inflammation and to heal someone's bowel and to have them grow and thrive and play football and tennis and hockey and whatever else they want to do in their lives, than not go that route. You know, I'm a big advocate of drugs and I use them in my practice every day, but I would still like to have alternative routes that are less dependent on that we can take patients on, particularly from early in their journey.
And I think in the future we'll see more of these combination therapies. Yeah. So we'll see more and more clinicians using, drugs, as Richard said, which aim essentially to block your immune system, and more dietary therapies, which essentially aim to eliminate the environmental trigger of the disease. And we have actually trials in our group where we try to combine these dietary therapies with advanced therapies, biologics that Richard uses all the time, in order to improve the clinical outcomes of patients. We know that even with some of these very expensive and state-of-the-art biologics, responses approximately 50-60%. We know that perhaps that if we combine these biologics with dietary therapies, we can improve this threshold from 60 to 70, 80%, which obviously will improve patients' outcomes, disease control, quality of life, and well-being.
And they're different mechanisms.
Yeah.
And I always say to people, I was giving a talk in Newcastle about diet and Crohn's disease just a couple of weeks ago, and I said you should consider it a free hit. When your patient's really struggling and you don't have an option, or they want to avoid surgery, or you're going to use a therapy but you think it's going to take time to work, then think about putting dietary therapy in there, particularly for motivated patients who want to do that. One of the challenges in adult medicine is the lack of availability of dietitians
Really?
to be able to do this safely and supported. But that comes from demand, and actually if patients want it and are looking for it, and gastroenterologists know about it and are recommending it, then hopefully that will become more available for people. And
do gastroenterologists get training in dietetics and nutrition as part of their fellowships and so on?
No.
We're not.
I'm not practitioners.
They should though, right? Surely.
A little bit.
Yeah, we get a bit. I think I'm not an adult gastroenterologist, I'm a paediatric gastroenterologist. I think we know relatively quite a lot about nutrition, because a lot of our patients are utterly dependent on us for nutrition, giving intravenous nutrition and adjusting their carbohydrate, protein, right, fat, calcium, magnesium, all these things on a day-by-day basis to get things right for them when they're very, very sick. So I think we know and think quite a lot about nutrition, but we're not dietitians, we're not trained as dietitians. And I always try to avoid having a go at somebody else's actual profession. That's not the way to success. I know what my role is, and I try to stick to that and get other people who are very good at their bit to do those bits. So,
and for children growing up, then what are the fundamental kind of core dietary principles associated with both promoting a healthy gut microbiota and also their success in terms of growth and thriving and so on?
That's a very broad question.
It is a very broad question.
They have to get enough energy and enough nutrients to make them grow. Whether this will benefit their microbiome or not, it's a contrary kind of like.
It's hard to answer that. I think I don't. I'd like to know more. I'd like to tell you more about that, but there's actually relatively little known about how. One of the things that's unique to children is that they go from having nearly no microbiome and nearly no diet to a full adult diet over that first few years of life. And in doing so, they establish their microbiome for the first time, and then they're a bit stuck with it for the rest of their days. So there probably is a lot of really important findings and a lot of really important things that we could identify in that phase and actually give advice about or make recommendations about. But we currently know very little about that, actually. And I suppose that I go back to the fundamental message from earlier, which is children should eat a broad and balanced diet that has all the key foodstuffs, that pays attention to things like calcium intake, and we shouldn't go taking things out of their diet without good justification or without specific professional advice about what we're doing and why. Particularly dairy. Kids really need calcium intake, right, for bone health, and as you say, vitamin D is important too. So same things: fruits, vegetables, variety, enough calories, that they're growing well, that they're thriving.
Fiber.
Yeah.
How does someone track their fiber then if they're not an expert? How does someone know if they're getting enough fiber in their diet? They have to look in the back of the foods, or
no, I don't think. I think they you cannot just monitor what you eat on a daily basis. This is not attainable. I think As we discussed before, you just try to follow the dietary recommendations about 5 fruits and vegetables a day. I think this is a good starting point. If you don't consume a lot of fiber, I'm sure you probably start becoming constipated. One of the most common symptoms of people consuming low fiber is constipation. But I don't think you need to actually monitor the amount of the fiber you consume. If you have a variety of plant-based foods, fruits and vegetables, you try to meet this 5 a day recommendation, I think you'll be on the safe side.
Yeah, and good hydration is important too. You mentioned constipation, one of the things that I always look to when I have kids who come in with constipation, which is a really, really, really common thing in our clinic. I think it's a facet of westernization almost, is to look at fluid intake and to ensure that people are actually drinking enough to remain hydrated. Because one of the important jobs of the colon is to take out fluid and electrolytes from what's left. And the more dry you are, the more it's going to work hard to do that. Whereas if you're nicely hydrated, it doesn't have to.
And the more short-chain fatty acids you have, the better the fluid and electrolyte absorption is in the distal colon as well.
Is that right?
Mm-hmm.
What do you think about obesity then, and the microbiota?
Difficult topic. So I think a lot of the signals we see there are secondary effects of people being obese. So obviously, if you're obese, your diet is very different to the people who are not obese in terms of the composition of the diet you follow, as well as the amount of the food you consume. So there was a lot of excitement about this topic, I would say, 15 years ago, when the very first papers were published with Peter Thurnbow and Gordon Jeffrey, where they saw that people who are obese had different microbiome to people who are not obese, and they had more firmicutes, and they assumed that they had a higher capacity to extract energy from fiber. But if you think about that, a person consumes how much? 30 grams of fiber a day at best. So if they meet the recommendations, so if we assume that 1 gram of this dietary fiber produces 2 kilocalories through fermentation in the gut, so the maximum kind of like energy excess could be pretty much 60 kilocalories a day, which is, I think, insignificant. But this is how the excitement started. So we have actually run a study in our own children's hospital where we try to study the microbiome of children who were obese against, so they had what we could call the common type of obesity, against children who had a disease which made them obese, like children who had, for example, a tumor in the brain, or children who were born with a condition which is called Prader-Willi syndrome, which is essentially a disease which makes you hyperphagic. And actually, believe it or not, when you compare the microbiome, there were no differences, which essentially tells us, yes, there were no differences in the microbiome. So both groups differed to lean counterparts, to the lean controls, but there were no difference in the bacteria between people who were what we call classically obese. So they had this non-pathological type of obesity compared to people who had this hypothalamic or genetic form of obesity.
Interesting.
Yeah, so this kind of tells us that a lot of the differences in the gut microbiome we see in obese people are actually secondary effects of the diet that the participants consume. This is, of course, not to say that gut microbiome is not important in the way that obesity affects your cardiovascular risk. Your metabolic health in particular. For example, we know a lot of things, a lot of food ingredients which make people obese are metabolized in the gut, and these metabolites actually can influence risk of cardiovascular diseases and atherosclerosis and cardiovascular accidents.
What could some of those things be?
Well, saturated fat. People were very much interested about this TMAO, which I cannot even remember what's the full term. So basically, these are, if I'm not mistaken, phospholipids, which go down in your gut bacteria. They are metabolized in certain types of acids, which essentially increase risk of atherosclerosis. This is out with my comfort zone, so I don't know much about that. But there's a lot of interest about these metabolites which are produced from the interaction between diet and the gut microbiome.
Is there any scope and merit then around this concept that the microbiota in obese people could be signaling up to the brain through undetermined mechanisms to say we're hungry, we want some more sugar?
I don't know. I don't think the microbiome makes people obese, probably. I think you get to obesity by, I always talk about seesaws, too much. You should have an energy balance between energy in and energy out.
Yep.
And one of the things about my patients that becomes problematic is that they're growing, which is a major source of energy out. And when they stop growing, actually they lose that. And so people who are gaining weight quite rapidly heading into late puberty are a real risk group for me, because I think that what's going to happen is they're going to stop growing and their weight gain is going to rise, faster, just because they've not expending that energy anymore. Right. So I think that's, if you're going to really distill where obesity comes from, it's an imbalance in energy in against energy out. Whether that almost certainly does select for a microbiome that is associated with that. Whether that microbiome, whether there's then a positive feedback loop from that microbiome that helps contribute to this sustaining obesity or driving that further, or, as you say, energy harvest, which was the thing that was quite fashionable for about 15 years, I think remains to be properly answered. But I think there's a lot of skepticism around that, and I'm not sure. I'm not sure that we're going to see microbial therapeutics come along and change the landscape of obesity. However, I suppose people have also got anxiety in the other direction, which is, can you confer obesity on someone through something like an FMT, And I know that there's been a lot of questions about that within those sorts of circles, but I haven't seen anybody come forward and saying, we have done this by accident or otherwise. They had someone who was lean and who had an FMT and has now become obese,
Only very small numbers of case reports. There was one high-profile case report about 3 years ago. But the systematic reviews that have looked back at all the studies, in some cases there have been donors who've been over BMI 25, and there hasn't been any trend towards increase in body weight. So that's kind of causative, I guess, if you're transplanting a microbiome from someone that is overweight and someone that's not. Do you have an impact? Personally, I think it could be important.
Sorry?
I personally think it could be important. It could be a contributor. I don't think it's the sole contributor. I think that's a bit far-fetched. And anything to do with energy harvest, I've really struggled with as well. On the basis that, are you really going to overcome, the relative effects of energy harvest versus what's actually going into your body?
But the other thing we have to also bear in mind is that, energy harvest is one way by which gut bacteria can regulate energy and fat deposits in the human body. The other way is by, for example, other type of short-chain fatty acids which have important roles in appetite regulation, like propionate through PYY, so through these gut hormones. So there's quite a lot of interest about this area in our university in Glasgow, where we have some of our collaborators who develop essentially new molecules, new ways to deliver propionic acid down in the colon. And they have quite a few at the moment, randomized controlled trials, try to explore whether they can actually suppress appetite and, of course, mitigate risk of weight gain.
What are some of the most common myths and misconceptions in the microbiome field in your particular areas of expertise and interest? We talked about the at-home gut testing, which is not really a myth or a misconception. It's just kind of something that isn't really valuable at the moment for people.
Yeah, I think people can make up their own mind about that, but they've probably heard our take on that, and probiotics. I think where do probiotics fit? What are probiotics, and why are these ones that I can buy, out of a fridge in a supermarket, not necessarily a great choice for what I'm trying to achieve? So we've talked a bit about that already. I suppose we've talked a bit about obesity.
Precision nutrition, that basically what you need to eat depends very much on your gut microbiome, and we touched on that. So there's a more and more interest about this area, more probably now than probiotics.
I think those are probably most of the things.
A lot of interest about fermented foods these days as well, and the benefits they may have on your gut microbiome and host health as well.
So what's coming next then for you, Richard, in your research?
So since I last was here, I moved to University of Dundee I'm setting up a gut microbiome lab there early next year with the support of the Children's Hospital charity, the Archie Foundation. So we're going to be setting that up in early 2024. Again, I suppose one of the things I'm quite interested in right now is that infant question. What happens to healthy infants and how do they colonise their microbiome, and what's important on that journey? So we're going to be putting a bit of energy into trying to understand that as one of our first projects. One of the other things that I'm going to develop, and Costas knows because I've been banging on about this for about 10 years, is to be culturing target organisms, from these diseases, so that we are able to interrogate the signals that we pull out of the molecular work to try and say, okay, we've identified this particular bacterium as important. Why?
Right.
What is it doing? What do we know about it? How does it interact with the host? All these sorts of things. And so also going to hope to set up targeted culture work, try and pull particular organisms out of different conditions. So that's what I'm going to be about, I think, going forward. And hopefully still collaborating with Costas and colleagues here and moving CD Treat forward.
You always.
Awesome, guys. I'm not sure how long we've been talking for, but I'd imagine it's quite a while because it's a bit of a time warp. I think we've been probably going for 1 hour and 40 minutes, an hour and 45 minutes.
Wow.
Believe it or not, it's 5 o'clock.
Has been long.
Yeah.
It's 5 o'clock. So from my perspective, we've covered all the things we wanted to discuss. Quite an interesting conversation. We've gone a bit off-piste, which I quite like.
The only thing you didn't touch
come on.
is, you talked about FMT, and this is obviously what you like doing, but you have never thought about FMT and dietary therapies. And we discussed that before.
Well, I've definitely thought about it. We talk about... So at Interbiotics, we're kind of obsessed with a few things. One is, how do we make this as an effective treatment as possible across the broadest range of patient populations? And part of that relates to the optimal composition. Part of that relates to, can we get the optimal composition every single time? Donor selection. Do we do a scale-up step? Do we add in a bioreactor fermenter to the process? Part of that relates to, do we give something to the donors to try and standardize their composition even more? We can't mandate it, but we could ask them to do it. Or do we, as part of the treatment algorithm, give something to the patients before or after? And there's you could draw a nice circle, right? Where you had this beautiful inulin, pectin, whatever it ends up being, that you ask the donors to take, which means that you're, in some respects, dictating the input material composition. Then before you give the treatment, you can give the same thing, perhaps, to promote, and then after the treatment to make sure you keep it going. So one of the big questions that we get all the time is durability of effect. Sure, this might work, but how long for? When do you need to redose?
Depends on the indication.
Depends on the indication. It depends on the patient within the indication. It depends on their diet.
But there's room for more research in that, because it's an area which, I know that a lot of people are interested in that anyway.
Tons. I mean, the future for me is a mixture of everything we've discussed today. I personally believe that if you want to make a lifelong commitment to change your microbiota, you need to make a lifelong commitment to change your diet. Or you take an Interbiotics capsule once every 3 months. Now, I'm not saying you get all the same benefits. I'm not saying that at all. I'm a huge, massive, passionate advocate for nutrition, exercise, minimally processed foods, eating your fiber, and that's part of the reasons why I'm doing this. I think it's really important. And one of my biggest frustrations when I worked in the NHS was, well, first of all, why are we not feeding our doctors and nursing staff and everyone, through free food in the canteen? Why is it not just readily available, really good food? Promote the health of our workforce. Don't have our doctors worrying about what meals they're eating during their shifts because we're already working them damn hard. But that's a separate kind of thing. Why are we not giving our patients really good quality nutrition in the hospital? I mean, we're trying to make them better as fast as possible. Yeah, we're giving them...
We try to do that.
Guys, it's
cost effectiveness.
It's mad.
So it has to come out of the budget.
But it's mad. It's like I remember walking around going, well, first of all, our nursing staff station is just loaded with chocolate and sweets and stuff. It's just not good. But our patients are the people we're trying to make better here, and we're giving them iron brew, tins of juice or sugary apple juice, which, by the way, is not, just for anyone listening, is not healthy. These concentrated fruit juices are just not healthy. Crisps, white bread, and a slice of ham. It's like, sorry,
I think people.
Have we actually thought about this?
Well, I think it's something because people tried to change that in the Children's Hospital when I was working there as a researcher, and we gave them healthy food, but most of this food ended in the bin because people wouldn't eat it, and they will go down to the canteen. Yes, and it has actually happened.
Right.
It was
fair enough.
With the previous dietetic director, so they tried to give children healthy food.
Yeah.
And they say, yuck, I'm not going to have that. And then they just took the elevator and went down to ground floor.
Didn't know that. That's good.
Well, there you go. So maybe my pipe dream is, it's not, maybe it's not realistic.
Change is difficult.
Change is difficult, particularly when you're sick.
Really
and your
difficult.
appetite is not great.
No, I hear you. But on the FMT side, there's huge scope. And it's not just FMT, actually. It's not just FMT. It's not just the full spectrum therapies. It's the single strain, the defined consortia. It's everything that's microbiome modulating in nature. Can we potentiate its effects? And on your side, I guess, patients with IBD, patients with liver disease, can we potentiate the effects of biologics, as you've discussed? We talked about immunotherapy by changing diet and maybe something like an FMT. That is where I see the world and the future going. And fundamentally, I believe that within our lifetime, all of us will be doing something for our microbiome that will be a little bit more guided. And I do have a vision that I think a lot of patients in hospital who've got this really damaged microbiome, defined by reduced diversity, increased pathobience, we see a lot of VRE, we see a lot of CRE, see a lot of multi-drug resistant organisms, full stop. Can we give all of these patients something to just reset and recalibrate? Reduce the risk of translocation, reduce the gut epithelial integrity damage, and somehow, through reasons we don't fully understand, enhance their responses to drugs.
Yeah,
that's. I believe that, and I come across people a lot in my line of work as someone who's running a company trying to do this, where they say, microbiome's it's not important. It's the thing, but it's not important. And I usually kick back by saying, you say it's not important, but that eating salad and fruit and vegetables is a good thing for you, right? And then they say, oh yeah, I went on this diet once, I felt really good. Well, that's your microbiota. I sometimes give the EEN example because I think it's just such a powerful example of dramatically changing your microbiome through your diet and having a profound impact on a defined objective disease. IBS is a little bit more difficult, but people do see profound benefits through dietary manipulation in IBS. It's well known. So to bring it back to the FMT EBX 102 thing, definitely, if there's anything that can enhance the effectiveness, that would be great. Now, in our clinical studies, we're building in, I'll call it rigorous, because I think it is rigorous, analysis of the patients before and after the intervention at defined time points for 12 weeks. We'd rather do more if we could, but there's a cost-benefit analysis to all of this stuff, right? And we're not just looking at what's there, we're looking at what they're doing. So we're doing the metabolomics. Now, we're not doing untargeted metabolomics, I think that's a fishing expedition. We're doing the short-chain fatty acids, we're doing the bile acids. We're looking at ammonia, for example, and HE, which is likely to be important. And it's through all of that kind of analysis that we might be able to determine what can we, what trends do we see here? Maybe we can apply some machine learning. How do we make our product better, but also how do we prepare the patients better? Because I fully agree with what you're saying. You gave a beautiful analogy about cancer, and it's not a unidimensional approach. I mean, look at these allogeneic hematopoietic stem cell transplant patients. It's a huge pre-treatment regimen.
Yep.
I think we're probably going to get to the same thing in the microbiota.
But they didn't start there. They started incrementally and they built it up.
Yeah. I don't like the idea, I have to say, of giving antibiotics. Just, I get a bad gut feeling about, excuse the pun, giving antibiotics as a pre-treatment mechanism to promote engraftment. Now, you could counter and say, well, what are you going to do to promote engraftment if you're not giving antibiotics? That's a difficult one because you're unlikely to get as dramatic and as broad an effect as an antimicrobial because it's specifically designed to kill lots of different bugs, right? You could say phage therapy or bacteriocins, I don't know. But fundamentally, we're opposed at our company to antibiotic pre-treatment.
Mm-hmm.
Because I think AMR is a big problem.
Mm-hmm.
And I really struggle as a former clinician, and obviously never made it anywhere near as far as yourself. I sort of did a year and decided I wanted to develop new medicines. No regrets, just FYI. I really struggled with this concept, which was, you don't actually have an infection of any sort, because we checked that. But we're actually going to give you this really broad spectrum antibiotic. And by the way, it probably is going to increase the risk of antimicrobial resistance in your body. But we need to do it so that this other microbial drug works. I struggle with that a little bit longer term. And I think politically, these companies are going to struggle. They're going to struggle to get uptake as time moves on.
Mm-hmm.
So they're developing their drug on the basis that you need vancomycin for 3 days before their drug. I think they're going to struggle with that as time moves on and patients get more astute and they're going to say, no, I don't want that. So to bring it right back, I've been on a long ramble now, which is not against the rules of the podcast, but we want to discuss with the experts. I can absolutely see within the relatively not too distant future a pre-full spectrum product and a post-full spectrum product, or a pre-full spectrum diet change and a post-treatment diet change.
Mm-hmm.
And by the way, I don't just apply that logic and framework to what we're doing. I would say the same thing for surgery. I would say the same thing for immunotherapy. I would say the same thing for biologics. Maybe not the same protocol like pre and post, but as part of our thinking, I think, as people working to make people feel better, diet and microbiota should feature in all of our discussions for our patients, I believe. And it might just be as simple as eat more fiber. Okay, cool. But why not? What have you got to lose, as you say, apart from in this specific setting of, which I think is fascinating, this paradox around fiber and inflammation. So I'll leave it there. We could talk more about FMT. I mean, I could talk about FMT until you're both withering away and needing another caffeine injection.
That's it.
But some of the data we have is actually now super exciting. So like when we first met, Richard, it's a long time ago now. It was still very much, we had a lot of work to do. It was very early, very nascent. It was kind of a bunch of students. Some of our data now is extremely interesting and powerful in terms of the composition of the product. How does it work in vitro models? We've dosed 24 patients now in our first clinical study. We've got this biological scaffold now that sits within our product that gives us better stability, preserves the short chain fatty acid and volatile products and metabolism.
I measured some of them for you last Friday, you know that?
Okay. If there's any data, tell me off the podcast. But yeah, thank you for that, by the way. I actually forgot about
I
that.
can't tell you the bill yet.
Forgot about that.
That's okay.
Thank you for that. Well, we spent the last 5 years trying to create the best full spectrum product on the planet. And we started with first principles thinking, which was around what do we want the end product to look like? Can we keep it stable long term at room or fridge temperature? Can we actually have a scalable manufacturing methodology? Because one of the reasons that 4D Pharma, to name one company, not specifically naming any one particular company, and others have had difficulties, I believe, in my opinion, not the opinion of Enterobiotics, is they used technologies like lyophilization. Now, I fundamentally do not believe that taking a vastly sensitive group of microorganisms through a series of temperature fluctuations over a long period of time is a good way to preserve them and dry them. I don't believe that. I think static temperature is probably better. I think there's better ways to preserve the viability of sensitive microorganisms in lyophilization. It's also very hard to scale. It's also very expensive, and it's a bit of a black box. So that's one limitation that the industry faces. I think the analytical techniques are also a limitation that the field faces as well, right? There's no one perfect technique. So how do you characterize your product? How do you make sure it's the same every single time? How do you characterize your patients? Because that's potentially quite important as you go through development. Is all Crohn's disease the same?
No.
That's
an easy question.
Is all use? Yeah, that's an easy question. No, that's an easy question. But is all UC the same? Microbial is probably slightly different. Are there responders and super responders and non-responders within UC? And can you determine that through the microbiome? Because if you can, then maybe it doesn't work for all of these patients. But if you can identify a group that it works amazingly well in, you've got a drug. Mm-hmm. And we didn't talk about the microbiome.com bubble burst.
Bubble bursting, no we didn't. But you just alluded to it.
But we're here now.
You just alluded to it.
I've been talking way too much. I need to stop talking. I'm surprised you're not both asleep. It's getting increasingly hard, as you know, for companies at the moment in the microbiome space. And we've not helped ourselves as an industry.
No, I think the path to market, we've talked about this before we came on here, I think the path to market is difficult, and I think it was relatively easy, if not actually easy, to generate venture capital support for a novel idea in this space when it was all new and exciting. It was going to change the world.
Right.
And there are very few products that have made it to market, and there are no big blockbuster adalimumab competitor products out there that are saying this has transformed this whole condition.
Yeah.
And so I think the availability of funds to support these companies has fallen away.
Yeah.
And with that, very rapidly, a lot of these companies, including ones that we've worked with, have fallen away. So it's disappointing. The big worry is that leads to the whole thing imploding and there being no space for any microbial therapeutics and the whole microbiome leading to nothing.
Yeah.
And I suppose one of the challenges is if you start to mandate, and again, the other thing we were talking about before we came on here was the FDA. There was a death of a baby recently, a premature baby in the United States given probiotics who died, and the FDA are starting to look more closely at the use of probiotics in extremely preterm babies. And I think there will be more of a requirement to test microbial therapies as if they were drugs, with the rigor and application of, oversight and review and objectivity and randomization and different phases and all these things that we usually associate with drugs. Whereas till now, particularly probiotics have been treated more loosely than that. And
our food.
That in theory has meant, a food,
that will kill a lot of probiotic companies.
Yeah, and that in theory has meant that the route to market was less expensive and quicker in theory, but actually in practice, as we've moved forward, we need to see that. And actually, of course, if you've had a inexpensive and quick route to market and your drug is not, your therapy is not too expensive to make, then why does it cost so much money? Or what is your price point for your product as it gets there is a big challenge as well for these things. So
it is.
It's been a difficult period, I think, for microbiome therapy, but hopefully there's been a degree of sort of Darwinian natural selection that some of these products were never really going to make it to market and were never going to be viable, and hopefully 100%. Some of the ones that are still around, including your own, will actually rise to the top and will become true products that we can give to patients and access in a healthcare setting in the near future. So
absolutely. Well, I mean, fundamentally, I think we need to help each other. I mean, I did a talk recently at this, I think for the first time I was an industry representative was invited to the UEG closed group FMT session. I don't know what some of the people were expecting. It's been quite confrontational in the past. We were debating each other through letters saying it should be regulated as a drug and so on. And I stood up and I said, here's the evolution of the field for the industry. And I presented a timeline. And then I presented a slide that showed the share prices of some of the companies they saw on the first slide. And what I said was, think what you want about motivations of pharma and biotech and so on. If the industry is not successful in this field, that will have a knock-on impact on the academic research and clinical research, which are both joined at the hip. A huge impact, actually. We actually want us all to win big, because it will flow back and cross-fertilize, just like it has in other industries, cell therapy being an example. I mean, you've got universities building cell therapy centres based on kickbacks they've had from drug discovery in the university that then went on to a company and became an approved drug. So we need to work together through these difficult times to help wherever we can, I think, because there will be successes. Microbiome is important, and patients are benefiting as we speak. More patients are going to benefit through CD Treat. That's brilliant. That's a microbiome intervention. So there's lots of green shoots and lots of positive news. When the times are tough, you need the evangelists and you need the people who just grit their teeth and just say, no, I believe in this and we need to keep going and push hard. And that's certainly what I'm doing. And there are microbiome companies raising money. There are microbiome companies moving forward. And there's been some decent data this year. Really nice data, actually. Some in UC, a consortium of 6 or maybe it was 12 microorganisms. Good data. Just statistically significant, I think, as in maintenance of remission. That's another thing. Is it inducing? Is it maintenance and so on? So we just need to maintain that momentum. And then, hopefully, there'll be more approved drugs out there and it will all flow back and wash through. So we're certainly doing our best at Enterobiotics. Podcast is important. Get the messaging out there to people. You've been great guests.
Thank you for having us.
Thank you for driving. Thank you for driving from Dundee and Costas. Thank you so much. It's been a pleasure. I've really enjoyed myself. I knew I would. And stay in touch. Thank you.
Thank you very much.
Cheers. Thank you.
Cheers.